Hello, hello, good evening, and welcome everyone to week 6 of Diagnosis and Treatment of Disease 2. Happy Tuesday. Hope all is going well as we start to enter into the midterm era of the semester. Midterm next week in this class. We'll talk a little bit about it before we go for the evening. I have a review document available for you. I'll give you some more information about the exam before class ends tonight. Tonight, we are going to go ahead and we are going to finish up our discussions on wind strike, wind stroke. We'll go over the last, we have about 5 or so patterns to finish up. So we'll kind of go over those, how to treat those, and then we'll move into a bonus lecture that you won't be tested on, the Xing Nao Kai Chao protocol, which is a contemporary acupuncture protocol used in China and other areas to help treat the after effects, what we call the sequelae of the stroke itself. But before we do that, please take an opportunity to log into MyPortico via the QR code on the screen there. Make sure you get tracked for attendance purposes. And I'll go ahead and open up the floor here for any questions, comments, or any positive news you'd like to share this week.
Yeah, I have something rad.
Excellent. Ooh, rad. Excellent.
Dogs are happy about it. We had a Shakespeare improvisation workshop in, of all places, 29 Palms, and we had about 20 people show up, which was amazing, and it was just a really good time. And I thought it was cool because it's a small town and it's Shakespeare, and it was just really awesome. So yeah, yeah.
Excellent. Excellent. Thank you for sharing. Always fun to have activities like that in the community. Excellent. Hope it was a good time. Anyone else? All right, well, positive news. Sounds kind of silly, but community events, Minneapolis, we do love to have our little neighborhood and community and citywide events. We had the anniversary of Prince's birthday and his death this past weekend. So shut down a big section of downtown Minneapolis for a Prince sing-along that lasted from about 2 in the afternoon until about 11 p.m. at night. Something like 100,000 people showed up for it. So kind of ridiculous. Minneapolis loves Prince. And so a lot of community activities for that. We're also entering into our art fair season here. It's like every weekend from here on out, there's some sort of art festival, art fair, art showcase going on all around the city. So kind of cool. Summer, we do a lot of creative stuff here. So I like to get out and move around. Got a little sunburned over the weekend, but all right. Well, let's finish up stroke, folks. And we'll probably get done maybe a little bit early tonight. We'll see where things are at. But we're going to finish up the patterns we have for stroke. And I said we'll introduce just sort of a little bonus presentation on acupuncture protocol for post-stroke, which I hope that you have an opportunity to at least experiment with at some point, either in your training or in your career. But you can always sort of tuck it in your back pocket as additional options to help support your patients. All right, well, let's take it away. Please log in if you haven't done so already, and we'll pull that down in about half hour or so. We've ended last week with 2 of our sort of our external patterns, right? We had our sort of our emptiness of the channels stroke, and then we had our organ stroke. And one of the main defining characteristics is that emptiness of the channel stroke can manifest as things similar to, Bell's palsy. And then the organ stroke can be a much more significant stroke that involves loss of consciousness and usually much more severe issues, but they can often come on a little bit suddenly. As you recall, the channel deficiency stroke happens in people who are healthy. They don't really have any potential risk factors or symptoms of stroke, whereas the organ stroke, people tend to have health issues, risk factors that could lead to that. But now we're going to be looking more at what we consider to be just the much more internally generated sort of wind type patterns. And as a reminder, when dealing with internal wind, we can't, that's not the diagnosis. We have to figure out what's causing the internal wind. Because remember, internal wind just represents an abnormal and sometimes chaotic or violent movement of chi in the body. But we need to figure out what's causing it. What's the underlying cause of that weird movement of chi? And it often comes down to either extreme deficiency or extreme excess. Now, on the excess side, we're often dealing with abnormal movements of the yang energy, phlegm, blood stasis, heat. Those tend to be some of the most common suspects. But the reality is, for these sorts of patterns, it's often can be a combination that can get pretty complex pretty fast. So mixed patterns of excess and deficiency is going to be quite common. And we're going to start our first one with a more primarily excess type pattern. And with that, what happens is, remember, we are treating the patients, our perspective for this unit is we're treating the patients after the stroke has happened. So the stroke has not been prevented, it has now happened, and we have to assess the patient to determine what is the state of their health and their chi dynamic post-stroke. And those are the symptoms we're going to use to help determine what pattern we're treating. And one of the more common ones that people are left with immediately following a stroke is liver yang rising with what we call wind fire. In some textbooks, they say hyperactive liver yang with wind fire, or ascendant, like rising upward, ascendant liver yang with wind fire. Now, this is a common internal wind pattern associated with stroke, and there's a strong excess presentation here. So in addition to the facial paralysis, the hemiplegia, so maybe the whole left side is paralyzed, we will see things like facial flushing, anger, headaches, vertigo, hypertension, red eyes, constipation, all of these really pointing towards that excess heat energy, right? Difficulty communicating, the tongue could sort of shift off to the side. This has a lot of excess characteristics to it. The tongue has heat signs on it, so red with a yellowish coat. The pulse also excessive, wiry and strong, wiry and rapid. Here we see typical liver yang rising signs. So the issues with the headache, vertigo, flushing, red eyes, irritability, etc. Sometimes there can be hypertension, so high blood pressure, HTN, hypertension. And many times patients who have this type of stroke have a history of hypertension that may or may not have been diagnosed before. Remember, high blood pressure is often called, the silent killer, because for many times there's not a lot of symptoms associated with it until it really progresses to the point where it becomes much more dangerous. Now, with that, what we'll see is we're going to be looking at a series of points that are going to sort of help open the orifices of the brain, clear wind, and redirect yang energy downwards. So gallbladder 20 is an excellent point for this. Because it can subdue the yang energy that keeps rising up. Some practitioners, and I haven't noticed much of a difference one way or the other. So if you do it, cool. If you don't do it, that's fine. Some practitioners for gallbladder 20 post-stroke will really feel around for like the most tender area of there. But, ultimately, I think just getting those points needled is going to be important. We also have by who? We have a DO20, governing vessel 20 there at the top. This can actually push the liver yang energy downwards. DO20 is an interesting point because when the yang energy is rising upwards, it can help descend it. But when the energy is going downwards, it can help pull it back up. In fact, when I worked on one of the prenatal units at the hospital, we would often have patients who were, in their third trimester of pregnancy and were hospitalized on mandatory bed rest due to a diagnosis I think is not a great name, but they call it an incompetent cervix, meaning that there was a threat of miscarriage. And we would use DO20, and even the nurses on the unit were like, "What is going on? This is working so well," because DO20 can also pull energy upwards. Antonella, you have your hand up.
Thank you. I feel like this question is so elementary, but I just want to I don't know, have conversation about it. But when you talk about the most tender point, it's like often I'll feel a point and I'm like, that's hard, like it's hard. And then other times it's like a cavernous, like squishy, you like sink right in. And then other times you really do get like a verbal um from your patient, like, yeah, like that's like the ashe. And then other times I just feel it like it's not emotionally, but I just feel like, ooh, like it feels right. But I don't know. So I guess when we talk about, you know what I mean?
Well, so what is like what is something about that doesn't make sense, or is there a question?
Like out of all of those options that I
Yeah.
laid out, can that all fall under the description of the tender point?
Sure, sure. And I think that's why, because of that sort of lack of standardization too, is also why some practitioners like, well, yeah, tender points, and maybe not tender points. There are certain points where part of the point location um, recommendation is to specifically feel for the most tender area in that region and then use that as the point. Other times, points are not really tender at all, right? So, I tell folks use it or don't use that process, but it's good to play around, experiment with it. Now, in regards to the different types of sensations, the way I typically interpret tender is if the patient notices that it has an increased sensation with palpation, like, oh, that hurts a little bit more when you press her. Oh, wow, I think you found the point. I have one patient where she has some quite a bit of tissue around her knee joints, and she has some dampness and some phlegm. And on her, I know that I will feel around the region of spleen 9, and there's always one point, and it's about the size of a dime. There's always one point in this larger region that for her, when I press on it, even with light pressure, is quite tender. And so I always needle her there. But once again, there might be other sensations too. If you feel like something is hard and tense, that could actually be stagnation.
Mhm.
If you feel something really, tender, maybe that point needs to be activated or tonified or things like that. So I'd say don't be too rigid in thinking about it and just play around and experiment. And what will happen over time, especially with acupuncture, is patient after patient after patient after patient, you will notice some of these sorts of idiosyncrasies, and you'll sort of make a mental note about, I think I am going to always feel for the tender point when I needle that point. I seem to get better results. And it might be purely anecdotal, but if you get better results, then you get better results. And another practitioner might not get the same experience. So play around with it, observe what you observe. Anytime I have any physical exam findings like that, such as tenderness at a point or a muscle group, I'll always use language like tenderness elicited upon palpation on the left paraspinalis muscle in the region of C5 to T2, something like
Mhm.
that. So always document the sensation. If you feel like a knot or a hypertonic muscle, document where that is too, because that gives you something also to circle back to the next time the patient comes in and says, last time you had a lot of tenderness in your low back. Do you mind if I palpate? I just want to sort of see if things have improved or not. Or last week, you had this really tight knot up by your right scapula. Do you mind if I palpate and press around here to see if that is still there? Because that could represent things like stagnation and stuff like that. So I think those physical sensations are important to acknowledge. They're important to get documented in that patient's progress note for that week and then follow up with it. But assigning meaning to it, there's a lot of different perspectives on that. So that's why I take a just more practical approach and say, develop sort of your own internal sort of database about what tenderness and what tight muscles and sore muscles and squishy muscles, what that seems to represent for you when you're working with your patients.
Right. Thank you so much.
Yeah, absolutely. It's a good question too. Not basic by any means, because it's one of those things where I think even in the textbooks they just say, "Ooh, feel for the tender point," but they never tell you why. They never tell you what it's supposed to mean or not mean. I think we get more of that depending on how you're trained, because some places do it differently. But like with ear acupuncture, I was always trained. You get that ear probe out, and you feel for the, let's say you're doing Shen Men in the ear. You always feel for the most tender point in that area. But once again, the ear is so tightly compact with points that just get a needle in the point is the sort of the way I
Yeah.
take approach it too.
And then there's teachers that say only needle into excess. So it's like, okay, if it's cavernous, it's squishy. That's not excess.
Right, right.
I don't know. Yeah. Thank you so much.
But that's also the thing, if it's squishy and it's musculature, is that dampness? Because if it is dampness, then it is excess, right? So I always
Right,
tell,
right, right,
yeah.
right.
So I tell folks like anytime someone says it's this way, is it? Because very few things are only one way in Chinese medicine, right? And so when you get advice like that, experiment with it. I mean, that's the great thing about this profession is you can do it for decades and decades, and you continue to learn more about patients' bodies just by being aware of what your hands are feeling, paying attention to sort of repetitive patterns with what muscles are doing, and you start to develop sort of your own internal vocabulary that will be unique to you and your practices, and then interpret that and go with that and then play around with that, and you get to experiment and see what works, because what works for one person just won't work for another person. And so I try to, many years ago I really tried to remove from my vocabulary when I'm teaching words like never or always, because that's just not how Chinese medicine works, right?
Right.
Oh, all right. So a few other points here to think about. So liver 2, liver 3, these are both great points to subdue the yang. In this case, because we're also dealing with excess heat, the wind fire, to pull it down and out of the body. I don't always needle liver 2 and liver 3 at the same time. I usually pick one or the other and then just thread to the other point. And for me, I like them both. But for me, the determining factor is the level of heat. If there is more heat, I choose liver 2. If there's less heat, I choose liver 3. But I certainly can needle in a way that will still hit both of the points regardless, as opposed to having to do 2 separate insertions. That's just a personal preference. Once again, sort of like, practitioner preferences. And so that's another thing that you can play around with. In your clinical practices too, dealing with points like that. Gallbladder 34, excellent point. This can also help subdue liver yang. I think people sometimes forget about that. Some people, we get so attached to it being a point for like muscles and tissues and stuff like that, that one of its energetic function is it can also help subdue the yang and help get the qi moving. And if the necks are particularly tight, the combination here of gallbladder 34 and gallbladder 21, which I don't have listed here, but you could also make a note of that adding gallbladder 21 with gallbladder 34 can help for neck tightness, which sometimes happens post-stroke. A lot of muscles can start to seize up. And then we have a combination here of our gallbladder 41 triple burner, triple warmer 5. This will help regulate the qi. This will help subdue the yang again. And it'll also help cool the energy of the liver. So help cool the liver yang energy too, and kind of redirect stuff in the body a little bit more downwards, or at the very least away from the head. Liver 2 is really good at draining downwards, but gallbladder 41 and TB5 can help move things a little more gently out of the space of the head itself. And then once again, any of the other points, like I said, this particular chapter has a lot of additional points based off other types of functional or motor deficits, so that you can add those into the mix. And as a reminder, these are the points that, you're responsible for memorizing from protocols. These are the textbook points, but there are other points that you can add or subtract based off preference and things and patient presentation. So you're not locked into only being able to do these. Let's see. All right. Really, really, really excellent herbal formula for all things liver yang, and that is Tianma Goteng Yin. Tianma Goteng Yin. This is our Gastroidia and Oncaria drink or beverage. This has a very strong energetic ability to calm the liver energy down. It can help get internal wind to become more pacified. It can help move blood while getting rid of heat from the system, because there's often a lot of stagnation. And it can also help with the liver and the kidney energies. It's really appropriate because this particular formula addresses both the branch, the wind and the yang energy, so the internal wind and the yang rising, and the roots by nourishing and supporting the liver and kidneys. Underneath this particular pattern, once we clear away the liver yang and the heat, you will probably find a patient that's deficient. And they're probably deficient either in the liver energy, liver yin, or the kidney yin energy, or both. So Tianma Goteng Yin is really good because it can help get rid of the excess energy and then start supporting the root. And in general, and once again, each person can kind of have their own therapeutic approach, but in general, in many cases, it is more appropriate to get rid of excess energy first, then focus on deficiency. In the case of, for example, spleen qi deficiency with dampness, if you don't address the dampness and you're only focusing on the spleen, you'll never be able to get the spleen back up to where it needs to be to transform the dampness in most cases, because the dampness, as long as it's in the system, is constantly attacking the spleen. It is constantly making it difficult for the spleen to do its job. So if you're only focusing on tonifying the spleen, whatever you're doing, your efforts are reduced as long as that dampness is in the system. So when confronted, in most cases, once again, not all, but in most cases, depending on patient presentation, if you are confronted with both excess and deficiency, get rid of the excess first. If you're confronted with an internal and an external pattern, clear the exterior first, then move internal. And that's just sort of a good standard across the board. But once again, you might find reasons with certain patients based on their presentation to do things differently, and that's okay. But in general, that's sort of our approach. Okay, liver yang rising with wind fire or wind heat, but wind fire is more appropriate. Let's move to a deficiency pattern here. So this is the one now that I had mentioned is primarily underlying the previous pattern. In fact, the patient probably was dealing with this for a while, and then it emerged into the liver yang energy being unanchored and violently shooting upward to the mind. So if we were to do a medical history on this patient, or maybe ask family members, hey, how is your patient, how is this individual feeling the last 30 to 90 days, we might actually find symptoms of liver and kidney yin deficiency that were evident. So what we say is that this particular pattern has a what we call a prodromal phase, and then we call this the catastrophe phase, or at least that's the language that your textbook has used before. The prodromal phase is in the background, the patient having this sort of chronic yin and deficiency, right? And if it's not addressed and not treated, then the liver yang energy comes rising up and attacks the mind. That's the catastrophe phase of the pattern. If the deficiency continues, the thought is then the liver yin energy just collapses entirely, giving rise to just pure liver yang energy that rises upward into the mind, leading to the stroke itself. So here we start to see, because there's that deficiency component, progressive unilateral motor dysfunction. One side of the body starts progressively losing its ability to function, as opposed to suddenly it's a little bit more progressive, starts maybe in the upper extremity and starts to work its way down or inferiorly. Weakness, numbness, paralysis, as we've seen with most of these patterns so far, facial paralysis. But now we're moving into more of the yin deficiency type symptoms. So tinnitus, remember malar flushing is the rosy cheeks, not a whole red complexion, but just the cheeks. Restlessness, insomnia, and changes in consciousness, etc. The patient certainly could also have things like some night sweats that are happening here. We do see the visual changes potentially happening. And once again, high blood pressure, hypertension is making its sort of appearance in another one of these patterns. But we're going to see hypertension not only as a medical condition, but also as a symptom itself. So in this case, hypertension is a condition to be treated, but its presence also indicates to us that there's one of these sort of liver yang energy type patterns. In this case, the liver yang is rising because there's not enough yin energy to tether it or to anchor it down. Tongue red, little to no coat. So that little to no coat, that can also equal what we call a peeling coat, or if it's more extreme, the mirror coat. That's where it's like the whole tongue is just smooth like glass, right? And usually pretty dark red. The papillae are completely smooth. They're not bumpy or anything of that sort. Pulse can be fine or wiry and rapid. But with this, once again, the patient is very likely has been dealing with some of these symptoms before the stroke has actually happened. So that progressive motor dysfunction could actually be happening, while they're at work. They're starting to notice things not functioning or working correctly. They could start to feel numbness or weakness. There's a sign that something's coming, right? And if we were to look at their overall health over the previous months, it probably was a patient who has more obvious signs of deficiency. So this is where, deficiency of certain types can actually lead to very life-altering excess conditions, right? So excess can still be rooted in deficiency. All right, so for acupuncture, here we're going to be looking at, once again, a lot of similar points. So we've already addressed DO20, gallbladder 20, the combination of the points 41 TB5, gallbladder 34, liver 3. Now we're looking at adding in kidney 3 because that's going to strongly nourish yin. And then we're going to strongly nourish the liver and the kidney shu points, respectively. So UB18 and UB23. One of the challenges that I have with some of these recommendations is, it's easy for editors and authors of a textbook to say, well, this is what you should do. This is what you should do. But the reality is, if my patient is half paralyzed and they're in the hospital or they're in a facility post stroke, some of these patterns or these protocols from the textbook rely a lot on points on the back. That is just not going to be an option for many patients. It is just not going to be an option to put them face down when they're half paralyzed and semi-conscious, right? So this is where we also have to take things with a grain of salt. Yes, these are textbook, but are they practical? They might not be practical. That was probably one of the best trainings I ever got in my hospital when I was treating in the hospital for 10 years, and things that were never really addressed in the classroom setting. And once again, this was 20 years ago. But you might find yourself or the patient in situations where there's not a lot of real estate to work with. So, I remember when I started an internship in the hospital before I was employed, one of the first lessons my mentor showed me, we walked into the ICU and she asked me, okay, so what points do you think we should do? And I listed off all the points, and they were technically correct. Like, they were the textbook points. And then her name was Jennifer Blair, and she was the intern liaison for the hospital. She was a licensed acupuncturist. She said, Christian, yes, that's technically correct. Look at the patient. How many of those, 8 points that you just listed are you? And we were in the neurological ICU. So imagine someone in the ICU and all the monitors, all the devices, all the leads, the probes, the IVs, the PICC lines. She said, how are you going to needle any of those points? Come up with something different. And in that moment, like, I got nervous, like, oh my gosh, like it didn't even occur to me, but this is the reality, right? Very few of the points that I had correctly identified as being helpful for this pattern and this condition were actually workable because of all the different devices and leads and IV lines in the patient. We didn't have a lot to work with. We had scalp and ear. That's about it, scalp and ear. And so the lesson I remember from that is, yes, textbooks guide us, but you also you have to needle in a very practical way too. You have to work with what you got. And secondly, look at the patient before you decide how you're going to treat it, right? Because had I actually sat and examined the patient visually and just like, oh, yeah, I don't really know how we're going to needle, kidney 3, or certainly none of the back points are going to be an option. Can't get to gallbladder 20 right now. Guess we're doing ear points, maybe scalp points. So give yourself that flexibility also in the real world when you're working with patients. Don't ever feel so confined to having to do what a textbook says, because that textbook is under ideal situations. And you will have many patients who are not presenting to you in ideal situations. Okay. And I think it's important to keep reminding folks you have permission and freedom to be flexible with point selection, things like that. Now, you have to pick the right ones for your tests and your boards, but in real world practice, you have to be flexible. And remember, all of your board questions, all of your questions on my exams and everyone else's exams are going to be based sort of off ideal patient cases, right? Where you have the ability to needle whatever you want to needle, to choose whatever points you want. But in the real world, that's not usually how patients come to us, okay? Or we go to them. All right, so our herbal formula here, this is a sedate the liver formula. It also helps get rid of wind. Zhengan Shifeng Tong. This particular formula is going to be helpful in helping calm the liver energy, helping remove or sort of pacify any lingering internal wind, while also strongly nourishing yin and telling the yang to simmer down, helping tether the yang energy itself. There are there's handfuls of great formulas that are good at nourishing yin, right? However, we can't just deal with the yin. We have to deal with the after effects of what the yin deficiency has caused, which is that movement of the yang energy upwards, the agitation of the liver energy. So this is another great formula that will sort of take a multi-pronged approach. We'll deal with the internal wind while also pretty assertively nourishing the yin. Zhengan Shi Feng Tong. Any questions about this particular pattern, the liver kidney yin deficiency? Treatments or otherwise?
I have a question for the herb.
Yes.
Yes, I just saw a patient with the like tremors and have diagnosed with Alzheimer's as well, and very deficient. And I was like consider if any herbs can helpful, but then at the same time when I suggest that I was just assistant, and then from my senior mentioned that normally they take a lot of medication, so not really like willing to suggest the herbs to add on. So how like can we like consider the herbs in the case?
So in a case of, let's say, someone with like Alzheimer's who also has some internal wind type symptoms. Yeah, so number one, it kind of depends on the severity of the Alzheimer's, the severity of the tremors. Um, it gets into various complications regarding what sort of medications are they already on, and do they have the ability to take the medications, right? So um, how how negatively impacted are they by their Alzheimer's, right? If it's still early on and they can still swallow and take herbs and be conscious of that, Alzheimer's disease, without kind of grabbing some resources here, Alzheimer's disease from a Chinese medicine standpoint, especially when there's tremors, is typically going to be rooted in deficiency, starting with kidney essence deficiency, and that usually happens a little later in life. There can be issues with liver wind. There can be issues with phlegm obstructing the orifices. And then qi and blood deficiency, like pretty profound qi and blood deficiency. So with this, I think we could look at, if I were to just sort of off the cuff think of some TCM herbs that we could look at sort of building some formulas around. For the cognitive side of things, the memory issues, to help support the marrow, the sea of marrow, the brain, right? To help support the Shen, Shi Chang Pu can be helpful because that will open the orifices, which is a great thing. It can help improve cognition and memory. And if there is phlegm involved, which it could be, it can play a little bit of a role of that. Yuan Zhi, Yuan Zhi can help with the communication between the heart and the kidney. So that can be beneficial in those cases. It can help with memory and focus. And Yuan Zhi is often paired with Shi Shuang Pu too. So those are helpful. He She Wu, He She Wu can be helpful because this will nourish the liver and the kidney, will nourish essence and blood, which is why it's sometimes thought to be used to help when people are going prematurely gray, right? It is often used with cognitive decline. There has been some interesting research lately, actually laboratory research, that He She Wu in some folks can actually cause liver damage, like actual biomedical liver damage. In some folks due to the enzymatic reaction. So I'm always cautious and monitor patients on He She Wu because it can just be one of those potential side effects. We also have gochitsa, our goji berries. Those come to mind because that nourishes liver and kidney yin again, and that can help cognition. We often think of it for eyes, but it also can help with our mental component too. And then for the tremor side of things, so those first set of herbs, really we're focusing more on the cognition, the brain, the mind, memory, the marrow. For the internal wind, Bai Shao, Go Tongue, can be very helpful. Zhu can also be useful. Let's see, Go Tongue can help extinguish internal wind and helps with tremors, especially if the type of tremor they have is where the muscles are locking up, but they're still shaking. So like their muscles become rigid, but they're still shaking. Like, so you have like my fist closed, but it's still trembling. Gu Tongue can be useful for that type of tremor. Bai Shao nourishes the blood, helps the liver. That would be more for tremor due to deficiencies. Jumu, I think I mentioned Jumu. Jumu can anchor the yang and calm the shen. If they're sort of have tremors and agitation, maybe. And if the memory issues if they have signs of phlegm, so if with their Alzheimer's they have signs of phlegm, and you feel that's causing the cognitive issue, then ban xia and fu ling, ban xia, fu ling, two great herbs to help that. Ban xia transforms phlegm, now helps support the stomach, and fu ling we know drains dampness, which if there's phlegm, there's probably dampness. That also can help the shen. And if you want something more, boy, if you're looking for an herb that would be more aggressive for the phlegm, then we could look at like Dan Nan Xing, Dan Nan Xing. But if I recall, some sources say you should be cautious in elderly patients, so that it could be a little bit too aggressive, too aggressive. And then real quickly here, I'll get to Callan's question. And if we're thinking about formulas real quickly, so a formula that we addressed, I think last time with our tremors presentation, a D Tong Tong, our clear or sort of resolve phlegm decoction. That can be very, very helpful. And we could add in things like gochitsa, hushawu, and shuri wang, actually, if we wanted to help with the essence of the mind components. And another formula, one that I just mentioned in the last pattern, Tianma Gotong Yin. Another great formula, Tianman Gotong Yin, can be used for a lot of things, especially if there is any issues with tremors, even in the context of the underlying Alzheimer's. So I hope that gives you some things to sort of play around with, to sort of start with. Callan says, is this diagnosis mutually exclusive of liver and kidney, not liver and or kidney yin shui, but both? So it is a third diagnosis separate from liver, kidney, yin individually. This diagnosis can more lead to wind and possibly liver yang rising than just liver or kidney yin shui by themselves. So this particular pattern is the combination of both liver and kidney yin deficiency. So this is where they are both coming together to create. So that's the prodromal phase, which creates the more catastrophic event of the yang rising. Can a patient be just liver yin deficient? Yes. Can a patient be just kidney yin deficient? Yes. Those on their own typically don't lead to wind strike, though. They can lead to other symptoms for sure. So if I'm interpreting your question correctly, a patient could have any three of those patterns: liver yin deficiency, kidney yin, or liver and kidney yin deficiency. For the case of stroke, it's usually the combination of the two, because it's a much more deeper deficiency of multiple organs now at this point, of the yin of multiple organs. And both of those organs play a role in managing the yang energy. If, for example, it was just liver yin deficiency, there's usually enough kidney yin to still anchor the yang, so the yang's not going to go anywhere. If there's just kidney yin deficiency, but the liver energy is fine, if the yang energy tries to rise upward, the free coursing action of the liver will push it right back down. So it's when they're both deficient, we sort of set up this like internal perfect energetic scenario where both functions of liver yin and kidney yin are sort of now asleep at the job because there's too little of them, that allows this event of the yang to go rising. So I hope that answers the question. At least that's how I interpreted the question. So which one began declining first? Don't know. We might not necessarily know if you don't. So that's a very fair question. At this stage, if the stroke has happened, it might not really be relevant. But, and it also might be difficult to ascertain depending on, can you get a good medical history going backwards, right? So from after the event. And that might involve asking the patient or asking the family members. And if you're able to get a history that goes back a month or 2 or 3, you might then start to say, ooh, that sounds like they had liver yin deficiency first, or that sounds like kidney yin deficiency first. But it really depends. It really depends. So after the event happens, it's not necessarily relevant in that moment to how you treat it, but it is interesting from an etiology standpoint to sort of figure out, because these sorts of patients, especially the ones who have longer term chronic deficiency, are prone to find themselves in that situation again. Now, it does not mean they will have a stroke again, but if you have a stroke, that's a risk factor for having another stroke down the road, right? So if you were able to ascertain based off medical history and exam, if they're prone to one more than the other, then you could potentially counsel the patient, lifestyle, diet, maybe look at herbal supplements after we're past this stage of treating the post-stroke syndrome. Then we could look at more long-term care too. So that's where it is interesting. It might not be relevant to today's treatment, but it could be relevant to next week's treatment, or or a month or so from now, once they've started to move into the recovery phase. And it can give folks something to monitor for. If you teach their caregivers, the loved ones, family, partners, whatever, what the symptoms look like, and you're involved in their care as one of their medical providers, you are now then giving them a heads up of what to monitor for, and then you could start treating it prophylactically before an event happens again. And that's where, one of the things you would hear me say in CHIM 3, Chinese Herbs Intro Medicine 3, a lot is we need to be very proactive as providers. It's not just waiting for a patient to show up in our clinic, put some needles in, write a prescription, say, see ya next time. We are also have to provide appropriate recommendations for their ongoing care, giving them strategies, dietary strategies, lifestyle strategies, herbal strategies. We're taking responsibility for their care. It's not just, we're not mechanics. They don't just stop in because they need a tune-up and then away they leave. You're doctors, you're licensed medical providers. You have a duty to have a comprehensive assessment of your patient and come up with a plan. And that plan clinically is more than just what happens in the treatment room for that hour, right? That's the treatment that day, but what's part of the bigger plan? So you always want to be thinking about the big picture for your patient's health too, right? That's super important. You have to be thinking about yourselves the way like an old school family doctor thinks about your health, right? Think about like, 100 years ago, you're in a small town, there's that doctor, they've known you from birth and through your whole aging process, and they're concerned about your health of your lifespan, right? Once you start thinking that way for your patients, it's not just how many patients can you get in and out your door. You're a medical provider, you're their care provider for Chinese medicine. So think very holistically and think very long-term for your patients. I'm less interested in the short game when it comes to my patients. I'm more interested in the long-term game. When a patient comes to see me, I want to connect with them and develop enough rapport and trust that they will return for their health needs as they arise. I don't have to feel the need to try to fix everything in one session, right? And that's usually not a very effective way to practice either. Don't become the type of practitioner that has to feel like you have to have one herb for every symptom the patient has or one point for every symptom they have. Think holistically. Remember, we're not treating the symptoms, we're treating the patterns. Treat the pattern effectively and the symptoms start to fall away, right? Treat the pattern effectively and the symptoms will fall away. And that I think is a good, successful, long-term strategy to be a good clinician. All right, a few more patterns here. Wind, phlegm, and blood stasis. We can just call this phlegm and blood stasis, but the wind gives us insight into the nature of what the blood stasis and the phlegm are doing, which is causing stroke, right? This is sort of a pathology that is an internal pathology where the patient might not have a whole lot of predisposing symptoms, except for things like perhaps a little bit heavier set, maybe a little bit heavy weight. Many patients with this particular pattern will experience some level of qi deficiency. But with this, hemiplegia, facial paralysis, numbness of the extremities, etc., dizziness and vertigo, that's the phlegm, fatigue, listlessness, that's the blood stasis, digestive weakness is due to the underlying spleen qi deficiency, which has given rise to the phlegm. Disturbance of consciousness or cognitive impairment, that's the phlegm. Excess weight, that can be phlegm and blood stasis. Erectile dysfunction in men, that's blood stasis. So we have a sort of balance between these two different pathological factors. The tongue all over the place. Remember, so this will help you clinically like forever. When we have a mixed pattern where there's more than one pathology going on, very rarely clinically in the real world are you ever going to see a patient with 50-50? Like, oh, you have 3 symptoms of phlegm, 3 symptoms of blood stasis. It's usually, wow, you got like 7 symptoms of blood stasis and 2 symptoms of phlegm. Well, that's still enough to diagnose both. Maybe you have 5 symptoms of phlegm and 2 symptoms of blood stasis. That's still enough to diagnose both. So the tongue it's gonna be somewhere along that range. So here, the tongue could manifest any of the blood stasis characteristics, any of the phlegm characteristics, but because there's phlegm, there's probably dampness, so it could also manifest any dampness characteristics. Now, if there's dampness, that means the spleen chi is deficient, so there could potentially be spleen chi deficiency symptoms on the tongue too. And the tongue isn't that big. It can't have nice, neat little compartments where it shows you exactly a little bit from each pattern. Sometimes it does, and that's cool when it happens. But usually, whatever the energetic pathogenic factor that is the strongest, that will usually dominate your tongue findings. But still look for the subtle changes. So it could be mauve or pale, thin or greasy, swollen and scalloped, stasis spots or not, distended veins or not. Okay, so document what you see and then just go with it. Remember, use the tongue and pulse to help confirm your other symptoms, to help confirm your diagnosis, not to define your diagnosis. Pulse, wiry, slippery, weak. It could even be rough and choppy. So I'd say add another bullet point there for rough and choppy. It's not in the textbook, but my experience has found it rough and choppy because that's also the blood stasis pulse. So. Okay, a few new points in the mix here for this particular pattern. So number one, I want to bring your attention to is spleen 10. If you have blood stasis, please promise me you'll always needle spleen 10. If your patient has blood stasis, unless there's a reason you shouldn't, please include spleen 10. It's such an important point for blood stasis. That being said, if you can also include in spleen 6 and Li4 in a combined point protocol, even better. This will help move chi, move blood, and help keep the blood invigorated, as it also slightly nourishes the blood too. Spleen 6, spleen 10, Li4, excellent point combination for blood stasis. If you can only choose one, spleen 10. If you can do all three, please do all three. Excellent, excellent. Li4, by the way, also has an additional function of gently tonifying chi too. So that can also be beneficial because, if someone has blood stasis, they're probably blood deficient. If they're blood deficient, they're probably chi deficient. So that can be helpful. Liver 3, we've addressed. Remember, this regulates liver, chi, and blood. UB17, as I recall what the classification of UB17 is. What is the classification of UB17?
Influential point of blood.
Yeah, it's the influential point for blood. And this, back shu for blood, not so much the back shu for blood. So when it comes to UB17, we don't really use the shu point terminology for that because shu means transport point. This is sometimes called the hui meeting point or the hui influential point. So just a little bit of nuance there to the semantics of that. So influential point of blood. There's a question here in chat. If your patient is pretty deficient, would you still do the 3? Yeah, because spleen 6 is going to help nourish blood. Li4 nourishes chi. We can tonify chi, tonify blood. This can also help invigorate blood. This very, very strongly, I don't know, I couldn't find the word strong, very strongly moves blood, and Li4 can also move chi. So we're sort of getting like multiple functions of each of these points, serving multiple functions. So remember, if there is blood stasis, it has probably disrupted the ability for the organs to make more chi and blood because it's blocking the flow and the nourishment of those organs. So spleen 6, spleen 10, Li4 moves things. Spleen 6, Li4 also nourishes things too, right? Blood and chi, respectively. So great question. But your question also is something you all should be considering. If you have a patient who is deeply, deeply deficient, and in this case, we have these excess energies we have to get rid of, remember? So we're dealing with the phlegm and blood stasis. But if you have a patient who doesn't have a lot of excess energy and there's deeply, deeply deficient, less is more. Less is more when it comes to acupuncture or any of the manual therapies. Too much stimulation can actually start to deplete the chi even more. So to the point, to Antonella's point, in the case of patients who don't really have any excess energy and are purely deficient, choose your points wisely. And like I've had patients who are so deficient where I've chosen to do 2 points. So 2 different points bilaterally, so 4 actual needlings, but 2 points, and they actually start to get better relatively quickly. We have to adapt the body's what the body's capable of doing at that moment, right? And we can overstimulate, we can over invigorate blood, we can overly move chi, we can over tonify. So sometimes less is more. um, I shared an example previously where I was in the hospital and choosing points, and my mentor was like, "Hey, take a look at the patient." It's funny how history repeats itself, because 5 years later, I was now in my mentor's role as the intern liaison between the hospital and an acupuncture program here in the cities. And we had a patient who was an elderly patient, somewhat frail. They were on the neurology unit. They were not in the ICU, so they were more stable. But this person was like 80 pounds, maybe, and in their late 70s. And the intern I had was very gung ho about Tui Na and strong Tui Na. And his particular needling instructor, who I knew because I had the same needling instructor 10 years prior, was a needling instructor who's like, more is better. The biggest needles, the thickest needles, the deepest insertions, and you just, stimulate the heck out of those points. That's how we were trained back then, by some instructors. And so I asked the intern, so you want to do Tui Na? Okay, so tell me how you'd like to approach this patient with Tui Na. And he's just talking about all these really aggressive dynamic Tui Na movements where you're doing kind of like physical therapy while also doing the hand movements and stretching, whatever. And I said, I don't think that's going to work for this patient. He's like, well, what do you mean? That's the right approach. And he made a comment probably similar to what I would have been thinking back when my instructor asked me, said, I can show you my notes where I know I'm right. I said, yes, you might be technically correct, but that treatment is not going to be correct for this frail patient. What you just described would snap her in half, basically. And he was really offended. I said, and then I found myself in my exact, it was like in my, I was like, quoting my parent or something. I was like in the exact same place and said, Andy, look at the patient. Use your eyes and just look at the patient. Step back for a moment. Yes, your protocol is technically correct, but it's not correct at this moment, at this time, for this patient. And then it was like full circle. Okay, full circle. Like, oh, great. But those things are important, right? We don't lose sight of those. So yes, if you're overly deficient, we do want to be more cautious about moving things too much. That was the too long didn't read version. All right. For our formula, and and this also goes for herbs too. We want to be cautious about not overly invigorating either with herbs when we have deficient patients. If we have patients who are having bleeding disorders, we want to be real careful about how aggressively we move blood. In this case, though, remember, so we're talking about deficiency, but this patient, the primary thing on the surface right now, and I don't mean the exterior, but the most obvious patterns and symptoms is the excess, the phlegm and the blood stasis. So we are going to use a formula called Hua Tan Tong Wu Tong. Hua Tan Tong Wu Tong. This particular formula is going to help transform phlegm, and it's going to help open up the channels so that as the phlegm is transforming, it has a place to move and hopefully get out of the body. Now, with this particular formula, we have to be cautious, though, because it's slightly draining, right? We have, so Ban Sha can help transform phlegm, help the stomach, Fu Ling do the same, but we've got Da Huang in here, Da Huang. And with the Da Huang, we want to be cautious that we're not overly draining if there is underlying deficiency. If this patient does not at least seem as though they have any deficiency, then you should be fine. But if this is one of those mixed patterns where you see the phlegm, you see the blood stasis, and then you see symptoms of pretty severe qi deficiency or spleen qi deficiency, then we do want to be cautious. Then we want to sort of step back and say, let me approach this maybe differently. Maybe I will up the Fu Ling a little bit. Maybe I'll add some Chen Pi in. Maybe I'll drop the dose of the Da Huang from 9 grams down to 6 grams, or maybe even 3 grams, right? So those are things that we would take into consideration. And those are conversations, like I said, we get more specific about in Chinese Herbs Internal Medicine 3. All right, questions, folks, about wind, phlegm, blood stasis. Well, let's just keep going down the rabbit hole of getting more complex with patients, right? Because, well, stroke is a complex pathology. So the patient has some phlegm in the system. They may or may not have blood stasis. That phlegm can heat up. Sorry, folks, 1 second. Sorry, that was the emergency alert notice on my phone. I'm about 4 blocks away. We've had an active shooter and hostage situation going on for about the last 5 hours, and it looks like it just resolved. So that's good. Hopefully the helicopters will stop flying overhead. All right, so sorry for the interruption. That was probably an obnoxious sound. Okay, so as I was saying, if they have phlegm, that phlegm is naturally going to want to create stagnation in the body. It can disrupt the movements of the body fluids. It can disrupt the movement of blood. It can disrupt the movement of qi. Remember, anytime something stagnates, it has a tendency to turn into heat. It has a tendency to sort of flare up, and turn into heat. This particular pattern is one of the few patterns that we're dealing with in this particular unit, where this is a pattern of where we start to see the stroke actually evolving. So this pattern, it could perhaps actually be before the stroke has happened, right? So they're starting to experience stiffness in their tongue, maybe difficulty swallowing. They're starting to experience that facial or muscular paralysis on one side. They're starting, maybe you're having a conversation with them and their words are not starting to make sense. Their mind is not clear, but they're still talking to you. They're still standing there. They're starting to turn reddish, get a little bit bright, and they're starting to maybe drool a little bit. These are not good signs. These are not good signs. If you're familiar with a neuroanatomist and neuroscientist, Dr. Jill Bolte Taylor, she wrote a book called My Stroke of Insight. And she has a great TED Talk. And I think I have the video embedded in this presentation. If I don't, I can get it to you. And so she's a neuroscientist, a neuroanatomist, and she knows the brain really well, right? And she had a stroke. And she was like at home on the treadmill or something like that, if you all the details. And she noticed something was happening. So in the moment, she's like, something's happening to my brain. Something's going on. And she talks about how she called like her office, or she received a phone call from her office, like her assistant, and they hung up on her. So then she called back and they hung up on her again. And then the third time, they realized something was wrong with her. When it was all said and done, and I believe she had a hemorrhagic stroke, and I believe she had a stroke that they were kind of surprised that she survived. But she talks about how she remembers kind of collapsing onto the ground, and she was in her thoughts, she was conscious as her consciousness was receding, right? And she talks about how she's like, I might not wake up from this. This might be it, right? And then when she does wake up and she goes through a rather lengthy recovery process, she circles back and is like, you know, when I was calling you, why did you keep hanging up on me? If you remember all the way back to when the stroke was happening. And they said, I thought you were either drunk or you were butt dialing me because you weren't making sense. She said, well, what do you mean I wasn't making sense? She said, you were slurring your words. And she's like, no, I wasn't. I knew exactly what I was saying into the phone. And the other person's like, but that's not what was coming out of your mouth. So she was in the process of having a stroke and it was being witnessed over the phone. This is one of those patterns where this can be the first onset, the first symptoms, the first sign of a stroke starting to happen. Now, if that's the case, please call 911. And while you're waiting for 911, if it makes sense, you know, maybe, as long as you're not going to be in the way of the paramedics, You could potentially needle stomach 40 or stomach 41, or maybe start doing some acupressure there if kneeling's inappropriate. Pericardium 5, CV12. As long as you know help is on the way, you haven't delayed that process, right? You haven't delayed EMS. Do some acupressure if you need to. Support the patient. Make sure that they go unconscious, their ABCs, airway, breathing, circulation. Start life support if you need to, CPR. But, in the meantime, while you're waiting, just don't get in the way of the paramedics. Don't have all your needles all over this patient and whatnot. But acupressure, for supportive care in the meantime. So REN 12, strengthen the stomach and spleen. This is the moo alarm point of the stomach. Stomach 40, this is our phlegm point, right? Transforms phlegm, calms the Shen. Just like I asked you to promise to use spleen 10 for blood stasis, anytime you have stomach 40, anytime you have phlegm, promise you'll use stomach 40. That's what it does. That's what it's there for. Excellent point. Stomach 41, also great for spleen and stomach energy and help transform phlegm. And pericardium 5, which I don't use a lot. I underuse pericardium 5, not for any particular reason. I just don't use it that much. But this is another great phlegm point. It's another great phlegm point to help transform phlegm. Notice here, everything is phlegm focused primarily. What about bleeding the Jing wells or do 26? I mean, you could try it. You could try it. Once again, do not. So here, while practicing in the U.S. healthcare system, do not do anything that would delay or interfere with emergency care in order to do Chinese medicine, right? You're trained in BLS CPR for healthcare providers. You need to lean into that training first and foremost, activate EMS, and then think about if paramedics are going to be here in 5 minutes, maybe 10 minutes, what can I do that can provide support without taking a long time to have to clean up or put away or get needles out or things like that, or stop bleeding if the paramedics arrive. You want the transition to be as seamless as possible in transferring of care, because every second is going to start counting at that point, right? So you have to make some choices, but never choose in the American healthcare system. Never choose to do TCM instead of Western emergency management that you are trained in. Okay, so it's a good way to get sued. We'll just say that, right? Mariah says, why is it called phlegm heat with wind phlegm? So the phlegm heat is the phlegm is now combining with heat in the system. The wind phlegm is indicating the phlegm is also then causing the wind strike. That I think is probably the most straightforward way to sort of think about it. It recognizes that there's a couple different pathologies happening at the same time. The heat is only there because the phlegm stagnated and caused the heat. So it's not just its own internal heat. The heat is a direct byproduct of the phlegm, and the wind is a direct byproduct of the phlegm. So I think that's sort of why. I will tell you that the textbook that is selected for this course by the program, it's a great textbook. It's a very authoritative textbook. But I will say some of the names of the patterns are not the names that you would find in the Machiocha book or the Wiseman-Ellis book. And that's okay. That's okay. So some of it does come down to linguistics and translations over the generations, which is why I do try to give you alternate diagnostic names. If this was a Wiseman-Ellis textbook, like the blue textbook that you might have used when you had Fundamentals 1 or 2, this would have likely been called internal wind or wind strike due to phlegm heat. Okay, it probably would have had a slightly different name, but that's kind of getting into semantics of it. As long as we recognize the underlying pathology, that's the important part. That's the important part. So Mariah says, so to clarify, the phlegm has caused heat, which has caused wind, which has caused more phlegm. Other way, the phlegm has caused heat, and the phlegm has also caused the internal wind. So the phlegm can cause more than one thing at a time, right? Not all phlegm will cause heat. So this could have just been wind phlegm, but it's not. It's wind phlegm and phlegm heat. So the phlegm has just gotten into the system and caused all sorts of trouble. It's caused a couple bad things, right? So it's, these pathogenic states are not like, oh, phlegm can only do one thing. This pattern is calling out that the phlegm has actually created two scenarios. That's why the point prescription, for example, is so focused primarily on the phlegm itself. The phlegm is the big suspect in this one. Maya says, if someone already had a stroke, what can we expect needling or pressing on these points to do? Does it help with recovery? Is it damage control? It feels like we're trying to treat something chronic in an acute situation. So if they already had a stroke and they're now in recovery, so they've survived, what we are now doing is looking at functional restoration, either of their motor control, so get the muscular movement back, neurological communication, try to help open the orifices if there is some cognition issues subsequent to that. In the moment of the stroke, like in a situation you're waiting for paramedics. So I wouldn't do that. I wouldn't do that at all. But I'm saying that if someone is going to make a choice while you're waiting for paramedics, it's sort of damage control. I many years ago at another institution, different time and place, having a very similar conversation, because I've taught neurology for quite a few years now. I remember once saying, if a patient is having a stroke, you call 911 before anything else. You call 911. And I got called into the dean's office like later that week because a student had complained that I was disparaging Chinese medicine by telling them not to do 26, by telling them not to do Chinese medicine, because Chinese medicine is amazing and powerful and magical and wonderful. It can solve and cure everything. That is how some people in our profession think. And so a student actually went to the dean because I said, do not do 26. Do not do those things in lieu of calling 911. And that pissed them off because the student was they felt the need to have to protect Chinese medicine, and they felt I was attacking Chinese medicine. And I told the dean, I said, listen, we have to teach students how not to get sued also, and how also to help give that patient the best chance. In our medical system here in the US, you call 911 first. Everything else is secondary. You call 911 first, right? Except for certain CPR protocols where if you find them unconscious and they're not breathing, whatever. But 911's right at the beginning of everything for the most part. And so that's why I'm like, so now I hedge my bets to say, if you're going to do something, then do that. But 911 still always comes first. For me, and I love Chinese medicine, been doing it most of my life, I would not worry about Chinese medicine in an emergency situation. I focus on the Western medicine interventions. I focus on what we're supposed to do in those emergency situations from a Western standpoint first, up to my level of training. Then the rest is, we'll see. So that's sort of why. Andrew says, yeah, great way to lose your license. Yeah, exactly. So to my to your question, like I mention it because yes, historically, before Western medicine, before emergency management, that was the options we had in Chinese medicine. And I don't mean we, because we're going back even a generation before that, right? Before Western medicine, or if you were practicing in ancient China, then historically, we should honor the fact that they did try to develop strategies to deal with emergency and life-threatening situations. So historically, absolutely, because there wasn't other tools available at the time. But in the modern era, use the emergency tools at our disposal and then go from there. So like I said, kind of hedging my bets a little bit, I guess. I hope that made sense. I hope that story made sense. But I will tell you, you will run into people who completely, they disagree with Western medicine so much that they're sort of obscuring their common sense when it comes to things like emergency situations. They've convinced themselves that, oh, my patient's having a hemorrhagic stroke, I'll just bleed a few points and they will recover from it. Really? You honestly think that's going to happen? I don't think so. If it does, it's the exception, not the rule, right? And by saying that does not mean I am disparaging Chinese medicine, right? But every healthcare system around the world, globally, every form of medicine has its strengths and has its weaknesses, right? That's why the more tools you have in your toolbox, the better. Western medicine, for example, really crappy at dealing with chronic health issues, really bad at preventing chronic health issues. Emergency medicine, trauma medicine, Surgery, top notch, top notch, best in the world. In many cases, not all cases, but that's its strength. That's its strength. Chinese medicine, no, we're not good at putting the broken body back together, right? That's not within our toolbox. But boy, helping it recover after injury, excellent. Helping tissue repair, excellent. Helping prevent chronic disease, excellent. Helping manage chronic disease, excellent, right? So it is okay to acknowledge there's no one system that is good at everything 100% of the time. And that includes Chinese medicine. And that's not an insult to Chinese medicine. That's just the reality. That's just the reality. All right. Don't send me to the dean, please. No, all right. It's already enough transitions going on the way it is, right? All right. Just a couple more, and then we'll take our break here. I know we're a few minutes late, but we'll take a break, and then we'll have a nice thematic shift until we go into our needling protocol. Okay, Xingluo Shenqi Tong. Xingluo Shenqi Tong. This is sort of our, it's based off our Zhuo Shenqi Tong, our Order of the Qi decoction. This one is a pretty strong formula. It has up to like 15 grams of Da Huang. That is just going to start pushing everything down and out, right? The Mang Xiao is in there because it helps alleviate some of the more assertive downward draining energies of Da Huang. When you start looking at your formulas a little more closely, a lot of formulas that have a component of draining that include Da Huang will have Mang Xiao in it also. The Mang Xiao helps soften some of the downward draining of the Da Huang without preventing it. Da Nang Xing, once again, we mentioned this also, very strong, not recommended usually for very deficient or elderly patients. And then we also have our Gua Wo in this too. So our trichosanthus. So here we're trying to get rid of the phlegm and heat. And here's the deal, folks. Sometimes this sounds obvious when I say it, but a lot of times people sort of forget about this. When we are doing things like transforming dampness, transforming phlegm, when we are draining dampness or clearing the bowels of excess heat, those treatment approaches are literally causing substantial changes in the body, and those substances have to go somewhere. So when we have formulas that are strongly draining or strongly transforming damp or phlegm, it is normal to tell your patient to expect changes in their urination or their bowel habits. The dampness will literally be peed out of the body, be urinated out of the body. And if it doesn't go into the bladder, it goes into the large intestine. Because remember, the large intestine has the ability to reabsorb fluids. So it can take in the transformed dampness, and then we have like diarrhea. So anytime I give a patient a formula where that sort of transformation or draining is a function, I let them know, and you should do this too, this might cause an anticipated side effect, meaning we know it might happen, so don't worry about it. It might cause some changes in your urination. It might cause you to have some diarrhea or some more liquidy stools. That's normal. That is actually showing you that the formula is being effective. It is showing you the dampness is literally draining out of the body. So anytime you have a formula that does those things, that drains dampness, downward drains, let the patient know that there are some side effects that should be expected. If they don't happen, no worries. If they do happen, it's expected. It's part of the mechanism of how the formula is working. Okay, so always keep that in mind, because sometimes people forget, and then patients like, something must be wrong. I have diarrhea now. I'm going to stop taking my formula. Well, if you didn't tell them that that's a side effect that we expect to happen, now they're stopping to take a formula that's actually helping them and was actually being effective in the moment. So we want to educate our patients on those sorts of idiosyncrasies of the formulas themselves. Andrea says, when you prescribe this, do you tell them to take it at certain times to work around the adverse reactions? So it really depends on how we define adverse reactions. Having diarrhea when taking a formula with Da Huang in it is not an adverse reaction. It's expected. That's an anticipated side effect. And once again, that is actually part of the therapeutic mechanism. So it's not adverse. It might not be comfortable, but it's not adverse, right?
I
It's
didn't
not,
want to misspell diarrhea. That's why I didn't.
oh,
I'm just gonna be honest, Dr. CJ.
okay, okay. No, I get it. I'm like, hey, I've been talking about poop for many years, right? In as a healthcare provider, and sometimes I'm like, wait, two R's, two H's, one R, two H's, two R's, one H. Which is it? It's the same with amenorrhea and dysmenorrhea and any of the rheas, right? So yeah, no problem, no problem. All right, chi deficiency with blood stasis. There's probably some blood deficiency in this one too, but the pattern is highlighting the fact that we have chi deficiency. And remember, anytime the chi stops moving, chi and or blood can stop moving too. And it's usually both. So blood stasis. Now, in this case, because there's chi deficiency and the pattern title is designating blood stasis, we should read between the lines and assume there's probably chi stagnation also. Okay. If we move the blood, that will help free up the chi, that things will start moving again. But we don't have much to move because we're also deficient. So in this pattern, this is a kind of, this is a common pattern following the stroke. It is common for a patient to find themselves now extreme loss of energy with blood that is not moving in a vital way, which puts them at further risk for another stroke, sometimes very quickly after the initial one, right? So once again, these symptoms look pretty much the same, right? Hemiplegia, paralysis, etc. But now they're very pale. They're short of breath. They might even have a hard time catching their breath, even though they're lying there in the hospital bed. They are fatigued beyond, beyond understanding for them. Palpitations with noise, their heart's pounding even though they're not moving. Diarrhea, possible incontinence, prolapse, etc. I have a patient right now that has this along with yang deficiency, and he's in some of the latter stages of Parkinson's disease. And I just saw him yesterday actually, and it was hard. It was hard because he's getting to that stage now where it's progressively getting worse, the progression of his disease, and we're just trying to manage his day-to-day symptoms so he has some quality of life. And yesterday was a tough day for him. And he has all these symptoms except it's more on the dysphagia, drooling, slurred speech, and replace numbness and hemiplegia with tremors, right? But otherwise, everything else is exactly the same. And the addition of he's ice cold too, to the touch, and he's always chilled. So this is where we can also see, how one pattern can manifest as very different biomedical issues, but still pretty severe too. Tongue, pale, thin white coat, scalp swollen. So here we see on the tongue, we're seeing more of the chi deficiency. You could still see some stasis spots though, right? Pulse fine, choppy, or weak, or a little bit of each, all above. So this is a concept. So this is deficient plus excess combination. Yes, it absolutely is. And remember, in Chinese medicine, very few things are mutually exclusive, right? We can have things that seem opposite happening at the same time. So deficiency plus excess. We could have heat symptoms and cold symptoms. We can have an internal disorder and an external disorder all happening all at the same time. So never, as you move closer and more deeper into your clinical education, clinical practices, make sure you never get like tunnel vision, right? Never say, I know what this is. This is blood stasis. Okay. Is there anything else going on, right? Well, blood stasis doesn't explain their fatigue, right? Their fatigue is the chi deficiency. The blood stasis, unless they're like coughing up blood and they got blood stasis of the lung, which is quite unusual and rare, then that breathlessness is coming from the chi deficiency too. So when one pattern stands out, obviously, it might very much be that pattern. But I always tell folks diagnostically, be curious, be inquisitive. Your job when you diagnose is really simple, actually. It's hard to do, but the task that you have at hand is simple. Your job is to rule out patterns and rule in patterns. Your job is to exclude what patterns it is not, and to include the diagnostic patterns that are. And that's it. And we do that through the 4 examinations and all that. But where folks, not just students, even practitioners, right? Where folks miss the mark is when they try to take shortcuts and they say, I felt the pulse and they've got this one symptom, therefore it must be this. Really? You're going to diagnose their complex medical history off of two things, a pulse finding and one symptom, and the symptom is not in the chief complaint that they came in for, you're a bad practitioner at that point, or a lazy practitioner, one of the two, right? So always be curious. You have to strike the balance in your clinical practices of doing a thorough evaluation and assessment, but also not taking an hour to do it. You should be able to do a very thorough assessment in 20 minutes. Not when you're first starting out. Not when you're first starting out. The benefit of your clinical education is you have time, but you should be honing those skills to become more and more efficient over time, okay? All right, so a lot of combination of points here. Once again, is this a patient that you can be able to roll on their stomach to do back points? Maybe, maybe not. But if you have the ability to use all sorts of points, the first set of points here, the top point, LI4, 11, stomach 36, 6, these would all be appropriate to moxa if you want to moxa. You could certainly moxa these points. You could moxa the shoe points too, but you could certainly moxa these points. We don't often moxa LI4, but you can. It's not contraindicated per se. But LI4, 11, spleen 6, stomach 36, all of these are going to help chi and blood. It's going to help chi and blood. And if this patient is extremely deficient, we don't want to be too harsh. So we can help move the chi a little bit. We can help move the blood a little bit. We can help nourish the blood, nourish the chi, and unblock the channels. The back points here, 17, 18, 20, 23. So we have the meeting point, the influential point of blood, the shoe point of the liver, the spleen, and the kidney. These are going to tonify. We're going to tonify these, and it's going to tonify chi and blood. And we're going to hope that the body then is able to get things moving and keep things moving. This is a patient who post-stroke is probably going to benefit quite a bit from ongoing care. And if we can get that chi back up to good levels and we can get the blood stasis moving, we have a good chance of really preventing them from having a stroke again. This pattern can seem pretty intense, but once we start resolving it, it can actually have a pretty good prognosis, probably better than a lot of the other ones. Even though at the onset, it can be pretty grim. Once we get over that hump, therapeutically, there can be some good outcomes if we're able to keep the chi levels at a good point and keep the blood moving. All right, our last formula for the evening. This formula is really going to be good to help support chi and blood while moving things also. Bu Yang Huan Wu Tang. This is, we're tonifying the yang, so the yang chi, right, in this case, in order to restore the five. So, Huang Qi, great herb, right? Really strong tonification process. Xuan Shang, you're going to find in a lot of formulas that involve things in the upper part of the body. Xuan Shang can be used as a messenger or an envoy herb to bring the energetics up to the head, specifically up to the brain. So that's why you will see Xuan Shang in a lot of like headache, dizziness, sometimes even some tinnitus type formulas, vertigo type formulas, because you can help bring the energetics of the formula up to the upper part of the body. All right, folks, differential diagnosis. So there's a few concepts in Chinese medicine that could seem similar. So we've already talked a little bit about spasms and seizures, muscular weakness, weight disorders, fainting and funny turns. This would be just fainting. So a syncopal episode, loss of consciousness, but you return and you're not worse for the wear. And if you'd like, if you haven't seen it, I would ask that you dedicate 70 to 80 minutes or so. This is a link to the full-length documentary on YouTube called 9,000 Needles. I have a feeling most people have seen it at this point. If you have not, it was filmed quite a few years ago, actually. The short story, American bodybuilder who has a brother who is a documentary filmmaker. Bodybuilder has a stroke, is paralyzed basically from the waist down. Brother says, I'm a documentarian. Can I film your recovery process? Sure. Brother with the stroke goes through survives the stroke, goes through rehabilitative processes, starts to make adequate progress. Then his insurance says, okay, you're mostly recovered. He wasn't, but you're better than you were. No more insurance. Live with it. Live with your disability. Tough. Of course, he was upset because his body was responding to therapy, but now insurance cut him off. His church, his faith community, raised money and said, hey, we heard of a program. Go to a hospital in China for 90 days, 3 months, specific for stroke protocols. They raise money, send him to China. Goes to China, hospitalized 90 days. Acupuncture twice a day, physical therapy twice a day, Tui Na at least once a day, herbal therapy, dietary therapy, and modern medical cares. Went in a wheelchair, came out in a walker on his own. Called 9,000 needles because that's about how many needles was used on him. 2 different stroke protocols were used in the documentary, one involving e-stim, which was more to treat the pattern, and the standard stroke protocol. The second treatment he received every day was the protocol I'm going to teach you after break here, the Xingnao Kai Chao protocol. And unfortunately, so he made it back home to the United States, lived, got back into bodybuilding, continued to do okay. And then I think it was like 7 or so years later, he had another stroke that he did not survive, unfortunately. So, he was a younger guy, middle-aged, he wasn't, I mean, that's him. He wasn't that old when he had the stroke. Perhaps he was pushing his body just too hard, as a bodybuilder wanting to return to that life. Maybe no one sat him down and said, you probably can't go to that same level of intensity anymore right after your first stroke. But anyways, it's a good documentary. The documentary, he didn't die till, like I said, 7-10 years after the documentary. So there's no sadness to the documentary because it was filmed when he was still alive. So if you haven't watched it, please watch it. It's good. Your patients reference it. Some patients have seen, I saw that acupuncture documentary. So it's good to at least know what people are talking about. I think our pop culture as TCM practitioners, this is probably one of the better known documentaries here in the West about acupuncture. So it's there for you, the free version, full version, if you'd like it. Okay, folks, that's enough of me yammering at you. It is the top of the hour. Let's just do one more. We'll do a 10-minute break because the next presentation is not super lengthy. We'll then talk about the midterm, and we'll let you go after that point. So we probably won't be here for the full amount of time, but we've been kind of moving at a quick pace here. So let's just do a 10-minute. Then we'll sit back. What we come back to, you don't have to worry about for the midterm. So this is just the added knowledge for you to put into practice if you have these sorts of patients. So we'll do a post-stroke acupuncture protocol. I'll talk about some needling techniques and some of the dangers of this particular protocol. Then I'll introduce what's on the midterm, and then we'll let you go. So it looks like it is 6:58. Let's come back at 10 after, please, so about in 12 minutes. And then we will do a short little overview of an acupuncture protocol, and then we'll get you on your way. All right, so we'll see you in 12, folks. Get up, move around. And if you have questions, pop them in chat. See you soon. All right, folks. Welcome back. Welcome back. Okay, we're in the home stretch here, and we're going to go through this next presentation. You will not be tested on. So this is just added bonus treatment tools for the toolbox, but you will not be tested on this, not in my tests anyways. And we're going to be exploring a contemporary post-stroke protocol called the Xingnao Kai Chao protocol. This is a contemporary post-stroke protocol. It was developed in this past generation in China, and it has been found to be effective. And so it is one of the many standard protocols that is utilized in Chinese hospitals right now. This particular protocol was developed by Dr. Shi Shui-min. And by the way, this is an abridged version of this presentation. I do have one that's about 3 times as long. If you want to go deeper into it and the research behind it and all that, we can do more of that. But this is the abridged version to kind of give you a little teaser in this class. So Dr. Shi Shui-min was at the teaching hospital in Tianjin, and he had been both a faculty member and a researcher at that hospital for quite some time. And he began to develop a post-stroke protocol that was different than the ones that were being utilized because he found some of them were just not effective. So we just spent all this time to go over all the textbook approaches, and results will vary. So he felt that there was a need for something that was not so much about just dealing with the internal disharmonies, but actually just getting the nerves and the muscles to communicate again. To get those nerves and muscles to communicate again. So he developed the Activate the Brain, Open the Orifices, or the Xingnao Kai Chao protocol. This particular protocol was developed by Dr. Min, and during this tenure as a professor and researcher at the Tianjin Hospital, one of my needling mentors, Dr. Huang Ma, was a faculty member there. In the late 1990s, Dr. Huang Ma came to the United States and settled in Minnesota and took a teaching role at Northwestern Health Sciences University, which has one of the larger TCM programs at that time. That's where I did my master's level training. Dr. Huang Ma was a supervisor at what was called the Courage Kenny Rehab Facility in Golden Valley, Minnesota. This was a residential long-term care facility for individuals who had been discharged from a hospital, stabilized after spinal cord or brain injuries, but they were not medically stable enough to live independently, and they still had some rehab to go. So they would be discharged sometimes for a year to this other facility. This facility, the Courage Kenny facility, had a relationship because of Dr. Huang Ma, who was an acupuncturist. They had hired an acupuncturist on staff there. And he had started an internship training program there. It was really the first of its kind in the United States. And I had an opportunity to do one of my last clinical rotations there before graduation. Dr. Huang Ma learned the Xingnao Kai Chao protocol from Dr. Min, and Dr. Ma told us that the students that were taught this in China were asked by their professor that if they ever have the chance to please teach as many other acupuncturists this protocol because it was so helpful. So on our last day of class, Dr. Huang Ma, here now in the United States, asked us to swear, put our hands on our heart and swear that if we were ever in the position to teach this to folks, that we would also teach this in order to help advance it more. This protocol has now since, it's not formally adopted into any Western training programs per se as a required curriculum, but more schools who have worked with some of the original individuals in this have now started incorporating it into classes like this or needling classes and stuff like that. So I'm happy and honored to be able to share with you through oral transmission of this knowledge, the Xingnao Kai Chao protocol as taught to me by Dr. Huang Ma, as taught to him by Dr. Shui-Shi Nin. Okay, so this is a very different approach. This is all about needling technique. There's no e-stim involved, other things. There are other things you can do in addition to this protocol, but it is not the protocol itself. So this focuses on the Dumai and opening up the yin meridians. And its main component is really to try to get functional restoration of the extremities, to try to get nervous communication between the nerves and the muscles to help reduce the symptoms of long-term disability following a stroke. In China, what we saw in the 9,000 Needles protocol is they use standard protocols to treat the pattern in one of the treatment sessions, and that also usually utilized e-stim. And then in the second treatment protocol every day, so 7 days a week, twice a week, getting acupuncture, we then see the Xingnao Kai Chao protocol being utilized. This is a very aggressive technique, and I think one of the reasons it has not taken on as much here in the West is we do tend to needle more gently. And if you think you're needling aggressively, you need to go to China and see what they're doing. We do tend to needle more gently. And that is, I tend to needle very gently these days, even though I was trained during the era here in the West that more is more. Bigger needles, deeper insertions, more manipulation. Well, that's not my style. But when you're doing this particular technique, this protocol, you do need to be a little bit more aggressive. And because of this, we are trying to stimulate primarily the median and the tibial nerve, so in the arm and in the leg, and the aggressive nature of it, one of the potential adverse events is potential nerve damage. If you do the techniques wrong or too aggressively or too deeply, if you're unable to perceive that you're getting close to the nerve body, you could actually lacerate the nerve, causing longer term damage. I remember when I was in China in 2019, having an opportunity to go to Tianjin. I didn't get to meet Dr. Shui Ximin. I don't even know if he's still alive anymore. But I did meet one of his other students that's still in Tianjin, and we were talking about this. And it was interesting all these years later to meet a professor in Tianjin Hospital who was classmates with my professor, Dr. Huan Ma. And so we shared some stories about Dr. Ma. And then we talked about Xing. He said, "Did he teach you Xing Nao Kai Chao?" And I said, "Yes." And then he asked me, "Have you gone out and taught it?" And I said, "Yes." So following the lineage, right? And one of the things we talked about, I said, well, you said in the United States, we don't really see a lot of super aggressive needling anymore. We tend to be a little bit more conservative. A lot of people will sue and all those things. He said, and I said, but here in China, you have different expectations, different standards. And I said, what do you do if you damage someone's like median nerve? What do you do if you damage their tibial nerve and it causes longer term issues? And this other faculty member basically said, well, they're already paralyzed. What's the worst that's going to happen? And he was being serious. He wasn't joking. He was being completely serious. And I kind of said, well, I don't think that response would go over very well in the United States. And he said, no, probably not. No, probably not. So he recognized that they also take perhaps a more aggressive approach. Okay, so this protocol is really straightforward. It's not fancy. It's not like mystical. It's not like, ooh, here's the ancient Chinese secrets or anything. It's a pretty straightforward protocol, and it's more about technique, okay? And there are 3 primary points that we use in this. So P6, spleen 6, and do 26. Now remember, this is post-stroke, trying to help regain consciousness or cognition and reestablish communication in the lower and the upper extremities. So specifically for hemiplegia. Okay, so we also have some additional points that we call the supplemental points. These are points that based then on additional symptoms that the patient has that we can then include. So we have some additional points to help with the overall treatment, heart 1, lung 5, bladder 40. If they have difficulty with communication, gallbladder 20, 12, and Sanjiao 17. And then we also have Bren 23, Jin Jin, and Yu Ye. And then paralysis of the hand and fingers, LI4. Now, these might not seem like really special, unique points, but once again, it's going to come down to how we needle them and the technique itself. So, just real quickly, dysphagia versus aphasia. Aphasia, the loss of the ability to understand or express speech due to brain damage, so that can happen post-stroke. Dysphasia, deficiency in the generation of speech due to brain disease or damage. And dysphagia, replace the H with a G, and that's difficulty swallowing. Okay, so P6. Here's what we're going to do. You are going to have to make some adjustments based off the patient's anatomy and their overall, depth that we have to be. This would be a Wernicke or Broca lesion. It could be, but this is often, due to where the actual, it can come from other causes. So if the bleed is in that area, right, then that can lead to aphasia, dysphagia, etc. Now, with P6, what we're going to do here is we're going to needle up to 1 Sun. In fact, I have seen techniques of P6 being needled to where it actually tents out. Like you can actually see the skin tenting on the opposite side, not punctured all the way through. So we call that a through and through insertion. We don't need to do that here. But what we do need to do is we need to go right down to the median nerve. You need to be able to feel the change in texture. We don't want to lacerate the nerve, but we want to get the tip of the needle very close to it so that when we lift and thrust, that we are not thrusting into the nerve, but the vibration the vibratory wave that goes out in front of the needle from the up and down movement, the percussive force is sort of vibrating and stimulating the nerve pretty vigorously. So the needle point is not touching the nerve, but the force, the percussive force, the vibration of the technique is pushing itself into the nerve, right? So like the movement of the chi, basically. What we're going to do is we are going to do a lifting, thrusting, and twirling technique. So lifting and thrusting, up and down, up and down, up and down, while also twisting the needle and going up and down, up and down, up and down, up and down. And you should be able to do this at about 80 to 100 rotations per minute, if not more. And with the lifting and thrusting, we once again have to be careful not to be going into the nerve itself. So you have to maintain that intentionality while you're doing it. And we're doing the affected side, by the way. You don't have to needle bilaterally. And in this particular technique, we're not leaving the needles in place for the most part. We're getting in, getting the chi, doing the technique, taking the needle out. So we're going to do this for about 1 minute. 1 minute. This is where, once again, if you want to be good, actually, no, if you want to be a great acupuncture needler, you need to start developing your hand and finger dexterity, strength, and stamina now. You need to start developing that stamina, especially in your hands now. Now, do 26. Here we see do 26. This one, we're going to go up to half a sun. So think about how oblique you might need to go half a sun, right? This is for the patient who is having consciousness issues, or their cognition is not fully there, their consciousness is not fully there. They're not in a coma per se, but they're having difficulty really being alert, aware and alert times 3, right? We are now going to use the bird pecking method with this technique. So that basically means, while with the shaft of the needle, sorry, not the shaft, the tip of the needle staying underneath the skin, it's sort of like, imagine if you've ever seen like a chicken pecking at grains on the ground, dot, 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 tap, 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 tap. And we're going to keep doing this. Going to keep doing it until the patient's eyes start to involuntarily water. They're not crying, but it's creating a sensation. You know, sometimes when you like sneeze and your eyes want to water or things like that, we're trying to recreate that sensation. We're trying to open up the orifices of the mind. And when the eyes start to water, we know that things are now starting to circulate up there. So tap, 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 tap. And it's pretty forceful, right? We have to once again be cautious, because the trigeminal nerve, and some people will come up and right around to about here. You can sort of see where my cursor is going. In some folks, it can extend itself all the way down here. So if it does happen to go a little bit farther, we want to be cautious about not damaging the trigeminal nerve. Anatomically, not everyone's trigeminal nerve goes there, but for some, it does. And now the last of our primary points, spleen 6. So for spleen 6, we are going to needle this and locate it slightly differently. So here we are going to be a little bit closer to the posterior border of the tibia. So we're on the medial side where spleen 6 is, but now instead of going directly up from the medial malleolus, we are actually going to go slightly lateral and move into the posterior border of the tibia itself. With that, and Antonella says, do we have any visuals location? I can pull up some. I don't have it right next to me, but I believe, I haven't looked at it for a while. But if you have nope. There is a textbook called Acupuncture Anatomy. It's a hardcover textbook. It's about $150. I have one. I can try to scan a picture of the nerves of the face and acupuncture points. That would be a good one. Otherwise, if you have the Siren Pictorial Atlas of Acupuncture Points, that would also do an anatomy and vulnerable structure overlay with acupuncture points. I was thinking that maybe the Manual of Acupuncture by Peter Dedman, but I remember I don't think that does. So I can try to find some of that for you. Let me make myself a note here, just one sec. Fix nerves of face. points. So I'll see what I can come up with. But I know I do have some textbooks, some needling anatomy textbooks that do. Yeah. All right. So I'll post some of those resources in one of the announcement forums once I find them. So I want to make sure I'm getting the titles of the books names correct for you here, and the authors, because I don't know them off the top of my head. Okay. So now this one, we are actually going to put the shaft of the needle right against the bone. So if we have the bone here, we're kind of going right. Oh, that's not working on the camera very well. Sorry. Right up against it. So we're not going on the bone. We're going kind of right against the bone. So you can see here, the tibia is probably, the border of it is coming right along here. So we're getting the shaft of that needle right up against it, not towards it. We're going parallel, right up against the tibia itself. Lifting and thrusting technique. This time for lifting and thrusting, we're going to do a tonifying technique. Have you been taught in needling yet how we change from tonifying to reducing using lifting and thrusting technique? Anyone in your needling classes?
Yes.
Okay, so the way I was trained, hopefully similar. If it's not, well, then it's just another way to learn. When we do lifting and thrusting, it's like we have a plunger, right? The needle's like a plunger, and we keep the needle in the tissue itself. To tonify, we push down with more force, and then we gently lift up. Push, lift, push, lift, push, lift. Like we're pushing a plunger into the toilet. We're pushing energy, chi, into the point. We're packing it in. The opposite would be a reducing technique using lifting and thrusting. That is where we pull up with more energy and then gently reinsert. Now, we don't ever take the tip of the needle out from under the surface of the skin, so it still stays in the tissue, but we pull up with more force and then gently push in for reducing, like trying to suck something out, okay? So we're going to do this technique until the leg or the foot spasms involuntarily up to 3 times. And so think about this. They haven't been able to move their toes. And you're doing this technique, and all of a sudden, the toes move. We're doing something. We're establishing communication here again between the channels, the nervous pathways, the muscles, the collaterals. This is a good thing. We're going to keep doing that to keep trying to reestablish that nervous communication between the tissues. So lifting and thrusting, tonifying technique until the leg or the toes or the foot involuntarily spasms 3 times. This could take a little bit of time. So there's no set time limit here. It could take a little while. Once again, making sure that you're not hitting any vulnerable anatomy. So those are the 3 main points. Those are the 3 main points. And once again, it is more about technique. But wait, there's more. Now we're going to move into Heart 1. So Heart 1, these are called assisting points. So you could, the main protocol is these 3 points, right? So P6, do 26, spleen 6. However, if the patient's up for it and we can position them and do these things, then we can move into our assisting points. So Heart 1. Typically, what we would do here is we're actually going to move it 1 sun distal from where the normal position is. Why? Because we don't want to hit the axillary artery, and we have to be careful of the brachial plexus. So we're going to move it slightly away from the traditional point because we're going to be doing some aggressive lifting and thrusting techniques. If we go too close to the actual point, the structure of the vulnerable anatomy underneath, the nerve endings and the artery are so close, we risk piercing one or both. We don't want to do that. So we're going to slightly go offside. And by the way I was taught to needle Heart 1 is we actually locate Heart 1, we palpate for the artery, we actually pull the artery back, put the needle where the artery was, and then let go of our finger pressure on the artery. And if you do it right, the artery will rest against the shaft of the needle now, and the needle will start pulsing with the pulse. Is it worth the risk? Probably not. Are the outcomes better? Not necessarily. But Xing Nao Kai Chow, we're going to go ahead and we're going to move it 1 sun distal, so 1 sun away from its point towards away from the trunk. And we're going to go up to 1 to 1.5 sun, lifting and thrusting, reducing technique until the arm or the fingers and hands spasm 3 times. This technique will typically cause bruising. So if you're doing it to a patient, you should mention this to them, right? And get their consent that they're okay with bruising. Next, we looked at lung 5. So here we see how we're going to slightly flex the forearm, and we're going to needle down 1 Sun. Most people don't needle that deeply on lung 5, but you can if they have enough tissue there. If this is a frail 79-year-old gentleman who weighs like 90 pounds, probably not, probably not. But on an average patient or above average, you usually have more space there than you realize. So we're going to slightly flex the forearm, lifting and thrusting technique. This time, no particular reducing or tonifying. Once again, until the arm spasms 3 times. Here, we need to be cautious for the radial nerve. So we are on the radial side. Be cautious of the radial nerve. Remember, it kind of goes radial, median, ulnar nerve, and they all differentiate from the brachial plexus. And they all sort of join back up here in a little loop and innervate the hands and fingers. So we don't want to damage those. All right, here's an awkward one. So this is UB40. UB40. This is a little more extreme method of doing it, but it does show that you can do it on your own if you need to. If you don't have an assistant. If you have an assistant, it makes it easier. So let's say the patient is lying face down. I'm sorry, not face down, face up, and you cannot lie them face down. Well, we can still needle UB40, okay? A couple ways to do this. If you have an assistant, you would have them lift the patient's leg up to their level of mobility, right? Not everyone's limber. This picture implies the person's quite limber, the model. Most of your patients are not going to be that limber. One of the ways I was demonstrated this is you go to the affected side on a stool or a rolling stool. You lift the patient's leg up and you place their ankle on your shoulder while you're sitting there. So you're facing them, and I lift their leg up and put their leg on the shoulder with their ankle on my shoulder. I would then hold their knee with my hand, and then with my opposite hand from underneath, I would now locate UB40, and sort of in an upside down way, I would now do the technique approaching it this way. So that might mean you have to get a little bit lower, get on a lower stool, but you need to get the leg up off the air or up off the table and get under there and support it. If you have an assistant, they can support the calf muscle and the ankle, lift it up gently, and then you can squat down, get under, and needle from underneath like that. Done this many times. It feels awkward the first couple times you do it, and then it becomes normal. Then it becomes normal. And for the patients who you're doing this for, the more normal you feel it is, the less awkward it feels for the patient too, because they perceive you know what you're doing. You're a professional. You're a pro. Okay, physical therapists and chiropractors have put patients in all sorts of weird pretzel positions before. We do now and then too, okay? And yes, you can absolutely kneel it this way. If you were doing a different technique, so not the Xing Kai Chao protocol, if you just wanted to put the needle in, you absolutely could lift the leg up, put the needle in transversely, and then rest it back down against the pillow, right? And the needle could still be in there safely. But we have to do some stimulating here. So in this case, we are once again going to do lifting, thrusting, this time with reducing method, okay? Until there's 3 spasms again. Is the 3 spasms important? Yes. If you only get 2, is that okay? Yes. If it happens 4 or 5 times, is that okay? Yes. But we're aiming for about 3. If you only get 2 and you keep on stimulating and there's no more spasm coming, you can stop and move to the next section. But give it a little bit of time, right? Give it a little bit of time. So what does Xing Kai Chao mean? So that was here, the presentation up here at the beginning, just a reminder. This is the open the orifices and activate the brain protocol, or sorry, activate the brain, open the orifices. And what was the second part of the question here? Would you only do this for paralysis? Nope, it is only for post-stroke and only for hemiplegia. Only for post-stroke and only for hemiplegia of the affected side. So it's a very specific treatment protocol to treat a very specific deficit. All right. Next, we have a few more points to work with here. So these would be our points, gallbladder 20, 12, and triple warmer 17, when they have difficulty communicating. These points, once again, depending on their anatomy and how much tissue you have to work with, you can needle deeper than you are probably accustomed to needling, 2.5 sun, especially when you're going obliquely as opposed to perpendicularly. We can get the needles in there quite a bit. In this case, we are going to do bilateral now. So you see 6 needles here, and we're going to do twirling and rotating from 1 minute each point. So we can do 2 fingers. So maybe start up at gallbladder 20 and then work our way down. 1 minute on each point. So 1 minute on both sides of gallbladder 20, 1 minute gallbladder 12, 1 minute Sanjiao 17. If you can, you might want to encourage the patient to try to make sound while you are stimulating these points. How long after the stroke would you still do this protocol? Well, in 9,000 needles, he was like a year after his stroke and he still got benefit. The general consensus is among other protocols, so like the ones from the textbook, and if you're using e-stim, the sooner the better. Like as soon as they're medically stable and you can start doing acupuncture, that's when you should start. The same is true for Bell's palsy. You should start acupuncture as soon as possible after Bell's palsy. If the patient still has symptoms after a year, you're probably not going to get good results. And you don't use this protocol for Bell's palsy. This protocol, however, you can get results many months after the event itself. Like I said, the 9,000 needles, I think it was a year or more since he had his stroke, and he still got good results. Now, with this protocol, I'm going to share another story with you. So once again, at the Courage Kenny Center, Dr. Ma was doing some demonstrations for continuing education. So brought in some practitioners for a continuing education event. And he asked if I was still a student at the time. He asked if I would assist. So I came in to help be the little needle gopher, set up the clean fields, all that. And he had coordinated with the charge nurse to identify 3 patients that we could work with or that were willing to be worked with in front of a live audience. Basically, there was only like 15 people at it, demonstrating different neurological techniques. There is this one young boy. He was 14, 15 years old. He was a paraplegic. I don't remember the nature of his injury. I feel like it was a diving accident that went real bad. And had a spinal cord injury and was now at Courage Kenny residential, was told he would never walk again and was told he would never talk again either due to the nature of injury. And he had different shunts in his brain that had fluid buildup. He had all sorts of, he had a very challenging medical prognosis. And he came in, his mom brought him in from his room and volunteered him to be part of this thing. And so now in this case, he wasn't doing the Xing Nao Kai Chow protocol, but he was using some of these points. So I just want to share this story real quickly. So the mom said, we know, and he knows that he's not going to walk again. But if we could just do something to make it easier for him to swallow, and maybe even just and try to communicate better, that would be life-changing, And Dr. Ma said, okay. So Dr. Ma sort of talked about what he's going to do. And so he takes the head brace off the wheelchair because he had a motorized wheelchair that had a neck support, took that off. He's like, I'd like to needle the base of the skull. And the nurse said, oh, hold on. There's some shunts in there. So they brought the x-rays out. We looked at the x-rays. Dr. Ma is looking at the x-rays, says, okay, I know where to needle. No problem. I'll avoid the different shunts that are in there. And someone sent me a private message. It'll be clear in a moment because that's part of my story, actually. So he's needling the points and he's aggressively lifting and thrusting and twirling. And you could see in the boy's face that it might have been a little uncomfortable. And Dr. Ma just sort of put his hand on his shoulder and is tapping him and says, you're doing good. You're doing good. And we're all watching. We're not sure what to expect. And then he stops. And he says, okay, so we got the chi. He's like, I can feel the chi is in the area, but it's stuck. It's not moving anywhere. And all the musculature, the larynx, everything is just, he's like, I can feel it is stuck. And he's like, so we're gonna do this again. And he said, now he starts needling, I think it was gallbladder 20, starts lifting and thrusting on both sides again. And he now tells this young man, he said, try to talk, try to make a sound. And the kid kind of looked at him like, I can't do that, dude. What are you asking me to do? Right. And he said, just try to make a sound. Like, and he said, like, hum or sing if you can. And so he starts needling, and you could hear air being moved. Like you could hear air being moved over his vocal folds. And you could sort of hear this almost buzzing sound, this sort of sound. And he's like, good, you're doing good. Keep doing it. And the kid was getting frustrated. You could tell he was getting frustrated because he was trying so hard to make a sound. And the mom is like getting, impatient, and she's concerned that maybe this is stressing her son out a little too much. And while there's an audience, and he says, okay, enough. So then he leans in to the kid and whispers something to him. And we didn't know what he whispered. I found out later, but he whispered into his ear, and you could see the kid kind of looked over at him and nodded. And so Dr. Ma asked the mom to come and sort of kneel down in front of her son and to hold his hands, right? And he's like, one more round, Mrs. So-and-so, we're going to do this again. Your son, it's okay. And he taps the son on the shoulder again and says, okay, now. And so he starts needling again. And, sorry, it's one of those stories that still has some emotional weight to it after 20 years. He's doing the lifting and thrusting. He taps him on the shoulder, says, okay, now. And out of the blue, you hear, ma, mom, 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 mom. He keeps saying mom over and over as he's needling. And as soon as Dr. Ma stopped lifting his thrusting, it went like ma, it cut off instantly. And he said, good, you're doing good. You're doing good. And he said, he's like, he looked at the kid saying one more time, and the kid goes, yeah. So starts singing again, ma, mom, mom, mommy, mommy, mommy. And the mom starts crying. Half the practitioners are crying. I'm getting shook up like I am right now. And Dr. Ma says, it's possible. It's possible. And then he looks at the mom, he says, I can't tell you that you'll ever walk again, but I do believe if we keep doing this day in and day out, within the next year, you'll talk again. And I didn't mean to get emotional, but it was such a powerful demonstration right then and there of the beauty of Chinese medicine, right? Sometimes little steps are important. The mom was losing it. She's like, I haven't heard him say mom forever, and the kid was crying a little bit. So, like I said, half the audience was crying. And what he whispered, when I found out, because I was assisting him, and I asked Dr. Ma, I said, what did you whisper to him? He said, just tell your mom how much you love her, right? And she was able to say mom, and eventually mommy. Fast forward about 6 months, Dr. Ma and I were chatting over coffee one day, and he said, oh, you'd be happy to know if you remember, I'll call him Jacob. If you remember Jacob from Courage Kenny, I said, yeah. He said, he's been working with a speech therapist, and Dr. Ma sees him 3 times a week and just does exactly what he did that night as a demonstration. And he says, he can speak entire sentences now, entire sentences. And he said, the doctors are stunned. The speech pathologist is like, what did you do? He's like, acupuncture. We did acupuncture, right? So that was 20 years ago, give or take a couple years. So that it is one of those experiences, like as I was getting choked up telling you the story, that still has that emotional weight due to the power of these particular tools and that you'll be learning. And so never underestimate. Don't overestimate either, but don't underestimate at the same time. Okay. So did you say this was also for dysphagia speech? Yeah. Yep. So same thing, we do the same technique for swallowing too. So these additional points we can use for communication or swallowing issues, but primarily in the Xing Nao Kai Chao protocol, it's for communication issues. So Dr. Ma was not doing the Xing Nao Kai Chao protocol, but he was using these points in a very similar way to address a speech disorder. And it was beautiful, it was amazing, it was bittersweet. Very, very cool. Very, very cool. And what a gift as a student at that time to be able to experience that, you know, um, and to show that there's a lot of things that are potentially possible. All right. Li4, Hagu. Here, we're going to actually needle it in a transverse way that will allow us to needle 1 to 1.5 sun at Li4. So we're actually going to point the tip of the needle towards triple warmer, to Li3. And we're once again to use reducing, lifting, thrusting method. This point we use if the patient is unable to extend their fingers. Some types of strokes will have these tension type strokes where instead of the muscles being flaccid and unable to move, they're seized up almost like rigor mortis. So if the patient has clenched fists, we're going to needle Li4 about 1.5 sun, but we're going to point the tip towards Li3 instead of the traditional perpendicular insertion. And that will that will give you enough accommodation in the anatomy to be able to get in about as soon, if not a little bit more, And we're going to do this technique until usually what will happen is the thumb and the first finger will start to release. And then sometimes the second finger, right? The middle finger will start to release. So we just keep at it until we get the fist to unclench. And over time, if they stop treatment, it will probably start to close back up again. But 2 or 3 times a week, we'll be able to get long-term unclenching of the fists. I've used that technique. I have a patient who passed 2 years ago who had multiple sclerosis, and they were having extreme pain from seizing muscles, like muscle spasms that were locking up. And the patient just said, if I could just unclench my hands, it would bring me so much relief. If I could just hold like my bottle of water with my own hand and not have someone hold it for me. And so we did this technique 3 times in 1 week just at this particular point, and did aggressive stimulating, and was able to open up his hands at the end of the 3rd treatment, and the hands never closed back up until after he died, or at least till the day he died. So that's once again, sometimes it's just about technique. And trying things out. 2 needles showing you 2 different angles of attack, 2 different ways that you could approach it. So you can do a much more oblique needling, or you could do transverse. Sort of imagine, this is 2-dimensional. Sort of imagine this one was actually maybe under this one going that direction too. So 2 different ways you can try to get in that 1 sun to 1.5 sun. So you can sort of play around with angle. Which do I prefer? Whichever the anatomy allows. Whichever their anatomy allows. Right? There's not always going to be a direct right or wrong. Sometimes you have to experiment a little, say, okay, part of this technique works by the depth of the insertion too. So we want to be able to needle it safely and comfortably. So you might have to try a few different angles and just see which one works better. Sometimes it's just purely about not which one do I like better, it's which one does their anatomy allow. All right, another fun one. Here we're going to do REN 23. This would be for motor aphasia, or issues where the tongue has now become, maybe the tongue has become deviated because of the stroke. Maybe they can't stick it out. Maybe they can't pull it in. Maybe they're having difficulty swallowing. Here we are going to do lifting, thrusting technique again, up to 2 sun in depth, right? Once again, depending on the amount of tissue. So take everything into consideration, anatomy, size, and scale. And here, this is another technique that you can do until their eyes start to water, which you can actually see a glimpse of here in the picture itself. You can see where they had started to tear up a little bit, sort of going down their face. So another technique for aphasia or tongue-related issues post-stroke. This one, once again, can feel very weird. It can feel like plum pit cheese sensation when you're doing it right. In fact, when you're doing this technique, you should ask the patient, do you feel a lump in your throat? And if they say yes, you're probably doing it right. Okay, so those are the points. That's the protocol. Those are the points. And the points we mentioned after the first three, those are all optional. The first three are non-negotiable. The last set of points are assisting points are optional. Clenching of the toes, we can do so start with the spleen 6 point. Start with the spleen 6 point because that you're trying to stimulate the tibial nerve, which is what innervates the toes. So start with spleen 6 and see how it goes. If that doesn't work, not part of the Xingnao Kai Chao protocol, but you could certainly try a similar technique depending on which toes are not extending, but you could do something similar to the LI4 technique, but you could do it on spleen 3. You could do it on liver 2 and just sort of work in the regional anatomy that way. But spleen 6, spleen 6. All right, so here is our course of treatment. Twice a day for 10 days is one course of treatment. So here's the deal. In the United States, this is really hard to do how they do it in China. Really hard to do the way they do it in China. If you're hospitalized and in China and acupuncture is part of your day-to-day care, it's part of your day-to-day care. Here in the West, it's hard to find the situations where we can treat to the same level of intensity that they do in China. So in a perfect world, twice a day for a week and a half, 3 to 5 courses of treatment. So 3 to 5 weeks. So that's 30 to 50 days of treatment, basically. And, if you're doing this twice a day for 30 days, that's 60 treatments. If you're doing it twice a day for 5 weeks, or sorry, for 10 days, 5 sessions of 10 days, that's 100 treatments, right? So pretty intense. And I don't know anyone in the United States who's able to provide care in this way in their current clinical model. When I worked at the hospital, we had one practitioner. So we all had privileges, everyone in the hospital, but we had one practitioner specifically dedicated to the post-stroke unit because that department asked us to dedicate an entire full-time employee just to work on the post-stroke patients because the doctors saw such great results from the patients who were out of the ICU and were now in the rehab units, physical rehab units. Those who got acupuncture, either this protocol or eStim, had significantly better improvements than the patients post-stroke who did not, to the point where the doctors demanded that we had one acupuncturist on their unit exclusively. And so we did. And that was 5 days a week. So because we integrated medicine network on the weekends. And so that's cool, 15 years ago when MDs, when neurologists are saying, we want an acupuncturist on our unit just to ourselves for our stroke patients. That's a cool thing. And why? Because they saw the effects compared to the patients who weren't getting acupuncture post-stroke. So kind of a cool thing, okay? Then we look at outpatient treatment 3 times a week for several months. So once again, in China, they'd be getting this level of care in the hospital for a couple months. Once they were discharged, they'd be asked to come back to an outpatient clinic 3 times a week for probably a few more months. So this could be a half a year's worth of treatment, a pretty aggressive treatment. But if that means the difference between you being wheelchair bound and having mobility back, doesn't mean everything will be perfect, doesn't mean you'll have the exact range of motion, doesn't mean you'll have the exact life back that you had before. But once again, 9,000 needles, he goes in a wheelchair, he comes out on his own with a walker. That's pretty meaningful, I think, right? So Xingnao Kai Chao cautions and limitations. Already mentioned this. Peripheral nerve damage. That is the main negative outcome from this if you do it incorrectly. If you're not attentive to the sensation of the tissues under the needle, if you don't know what a nerve feels like, it feels like a rubbery cord when you needle it. You could actually be causing damage, especially with those aggressive lifting, thrustings. Remember, when you hit a nerve with a needle, it hurts, but you're dealing with patients who might have loss of sensation. They might not be able to give you feedback, hey doc, this hurts, like insanely hurts, because there's no communication with that nerve. So you could be shredding that nerve, lacerating it through your technique, which means you're actually going to make the things worse, right? So use your judgment. This technique is not for everyone. And I mean that by it's not appropriate for every patient. And to be honest, it's not appropriate for every practitioner to do either, right? It takes a certain level of assertiveness, but also extreme intentionality and care to not damage the nerve structures and to do it the right way. I have seen that there are some practitioners now who are now offering this training through continuing education. There's not a lot, but once you graduate, you can also check if you want to actually go see live demonstrations. There are people still like Dr. Juan Ma who do continuing educations at symposiums and workshops, and will demonstrate and do hands-on versions of these techniques. So if you have an opportunity and you're interested in neurology, I would encourage you to seek out that training. So now you know about something that a lot of other TCM practitioners in the United States who get trained in the United States don't know about. If you're trained in China, this is absolutely part of your curriculums. Here in the West, it's not really published in a lot of English TCM textbooks. So there are case studies that you can find on PubMed for this protocol. So it is being researched and has been researched for a while. But you now have insights, informations, and a tool in your toolbox that only a handful of institutions are able to offer TCM students in the West because they happen to have faculty members who are trained as the third or fourth generation practitioners of this technique. So, and honestly, I don't use this technique very often these days because I don't have a lot of stroke patients. So I hope it lives on in other practitioners, right? And I hope it lives on other practitioners. All right, that's all we got, folks, for that protocol. Any questions or comments before we talk about the midterm?
I have a question. I sent this in the chat, but you might have missed it. But
Oh.
I was just wondering, like, for one session, how long does it take? Like, can it fit into your standard 1 hour session, or do you have to like book a longer session, or how long does it take?
Yeah, it really depends. It really depends. So this particular protocol was designed to be done in hospitals, like where you're going into the patient's room, they're on the table, you already know what's wrong with them, they're not ambulating into your clinic, etc. In those cases, if you're doing the first 3 points, it could take you 20 minutes, 15 to 20 minutes to get everything squared away. If you're doing more, yeah, you certainly can get it done within 45 minutes for sure, right? Assuming your assessment and all that's already done. This is a very pragmatic approach. This is different than how we are trained in Chinese medicine to deal with things. So remember, in a Chinese hospital, when they're doing more than one acupuncture session like this, where they're using a specialized protocol, one of the treatments is probably focused on pattern identification, treating the pattern. This protocol is regardless of pattern. So it's more of a technical approach. You already know the patient's had a stroke. They've got paralysis on one side. You just go in and do the protocol. You don't worry about tongue and pulse. You don't worry about everything else. In fact, you don't even ask the patient too many questions because this is what you're trying to accomplish. That's a different mentality than how we're trained these days. But in China, that's still pretty common. So I think there still has to be some changes in our system in order to be able to really do this protocol the way they do it in China. But if you ever have an opportunity to go to China on a medical tour or to go spend time at one of the TCM universities, such as in Tianjin, Zhengzhou, even in Beijing, talk to some of the doctors, ask them about this protocol, and they would be happy to show you. Like, they want other practitioners to know how to do this, because in China, they all know how to do it. This is part of their standard medical training now. But yeah, 30, 45 minutes, for sure. Because sometimes, if we're waiting for those spasms, sometimes it happens within the first minute or two. Sometimes it might take 5 or 6 minutes for the limb to spasm, and then you move on to the next. But it doesn't usually take super, super lengthy. All right, let's talk about the midterm real quick. I do have a document posted in Moodle for you. It's under today's session, so midterm review. It looks a little bit like this. Here's the deal. So next week is the midterm. You do need to have your cameras working. You need to have a good internet connection. Log into class at the normal time. I'll be here. I'll be on camera with you, proctoring it. Make sure you have a good power source, good internet connection, and your camera is working. Please try to be on class on time. The exam will be closed until I manually open it. Once we're all settled, I'd like to say a few encouraging words for all of you. Then I'll open the exam manually for everyone. If you have accommodations, such as length of the exam, timing, for example, that will be programmed into your individual exams, but otherwise you have 90 minutes to complete it. You're going to be surprised at the brevity of the exam, but you'll find that the questions are pretty comprehensive. So I have the format of this exam is a little bit short, at least question-wise, but the questions are good questions. They're pretty fair questions. It's sort of going to be based off case studies for the most part. So first off, it's not open book, not open note, okay? You will be responsible for the patterns that I list, point selection combinations, herbal formulas, all red flags. You're responsible for any red flags and any relevant physical or lab exams that we mentioned specifically in class. There's a lot of other information that we could include, but if we didn't cover it in our presentations, you don't need to worry about it, okay? The topics and all the exam is structured in a way to make it easy to navigate. So each section of the exam is a different condition. So there's a headache section, dizziness section, tremors, and stroke section, okay? So each of these is set up. So there will be a case study that will give you a lengthy case. Some of the information is relevant. And just like a real world patient, some of the information is fluff, not relevant. You have to make sure that you synthesize the relevant symptoms that are associated with the chief complaint that match the tongue and pulse, and then you will find the right diagnosis. You'll be asked about the diagnosis. You'll be asked about treatment protocol, herbal formulas. You'll be asked potentially about red flags. And then you might be asked about lab exams, or I might ask you questions about pathomechanism. Why is that symptom happening? Or about etiology. Each section is structured very similarly. It is primarily multiple choice. There's some true false. There's some short answer questions, but no lengthy essays or anything like that. Headache, dizziness, tics and tremors, and wind stroke. Those are the 4 topics you'll be responsible for. There are, I believe, there are 20 questions. So there are 4 conditions, 5 different questions for each, and they're all interrelated. You know, if you get the diagnosis wrong, you might get the treatments wrong. So that's where it gets a little bit difficult. Why? Because that's how the board exams are structured. If you miss the diagnosis, you're going to miss the subsequent questions. So make sure you are getting good at diagnosing. And these questions are similar to how board exams are structured. Not the level of complexity yet, because you're still early in your training. I'm not trying to, make it tricky or anything. But it is structured in a way that's going to start getting you accustomed to board type questions. There's 20 questions and 42 points. So some questions are weighted more than others. Safety questions tend to be weighted more because, once again, in your board and in licensing exams, safety questions are weighted more. So it's going to start getting you into the feel of that. But the exam itself is not meant to be tricky in any way, shape, or form. It's straightforward. It's probably boring, actually, when you think about it. But the questions are fair. They're fair. They're not overly complex, but they're not straightforward and simple either. So you're going to read through a case, then you're going to answer the subsequent questions. When you're done with the exam, you'll be free to go. So I'm not going to make you stick around for a lecture or anything after the exam. And then I always, if you haven't had me in the past, I always do review the exams. I look for any abnormalities. If there are questions, I'll give you some instructions before the exam starts next week. If there's questions about an exam worded weird or seems, inaccurate, I'll tell you how to communicate that to me. And then I always, after the fact, go back. I review everything before the final scores are posted. So if I need to throw out a question or add points because of throwing out a question, I do that. Okay, so I try to be very fair about it too. I'm human. I've looked at this exam a couple times now, and I'll probably look at it again before next week. But I make mistakes too. Try not to, but I do the best I can to make sure there are no mistakes. But hey, I'm human too. So things can always be addressed after the closing of the exam. So there's a question about, let's see. Sorry, I just want to confirm the document is incorrect. We cannot use our notes. Oh, shoot. Does it say you can use your notes on here? It should not. Oh, well, thanks for catching that. Let me just hide that. I will upload a new document that doesn't say that. So thank you for catching that. You cannot use your notes. No open notes or open book. So thank you for catching that. I don't know. I'm just going to kind of correct that right now, probably. I will upload that at the end of class. So sorry about that. But no notes, no notes. And I'll upload the new document once we sign off here. I'll make that edit real quick and just upload the new one again. So apologies. Thank you for your eagle eye. Like I said, I'm human too. I'm human too. So good. Would have been studying a bit harder this week. Thank you. So no, you cannot use your notes. So you should be studying harder this week. All right. So you cannot use notes. Right. All right. So sorry about that. I will make that error or edit so it says cannot use your notes. We'll go from there. Next week, also, if you had me before, you know about this. I always post a little pre-exam meditation. This is about a 10-minute mindfulness activity that I recorded a while ago. It's not specific to this class. I try to make it evergreen. I post it in all my classes before the midterm, before the final. It's a guided meditation. This is me walking you through a guided meditation to help with any test taking anxiety, or to help you also visualize successful completion of the exam. So if you find those sorts of tools helpful, feel free to listen to it leading into the exam or right before the exam. If you don't think those things are helpful, then just ignore it. But it's there if you want it. It's there if you want it. All right. If you have if you just sent me a private message, yep, no problem. No problem. I'll stick around for a few minutes. All right, folks, that's all I got today. Oh, the other thing I'll mention. If you have any questions specifically about stuff related to the exam, please feel free to post them in the Ask Dr. CJ forum. Today is what, Tuesday? Please have them posted by Sunday evening. That allows me to answer them Sunday night and then people to review the responses by Monday. So if you need to post a question in the Ask Dr. CJ specifically about the test or what's or the topics of the test, like to clarify, something in the tics and tremor chapter or whatnot, please have that posted by Sunday evening, early afternoon at the latest, so that I can have some time to turn around and respond to it. All right. Sorry, I got a little bit emotional on you there for a little bit, but I've got like 4 stories in my career that still choke me up when I tell them. So that was one of them. That particular case of the young man with talking. So sorry about that. I don't get too emotional on camera usually, but sorry. All right. Well, I think that's it, folks. Have a great rest of your week. Take care of yourselves. I know midterms and tests get stressful. Keep your Shen balanced. Don't overwork yourself. This next week is the time to just say no to things, right? Just study, get some good nourishment, get some good self-care, and tell everyone else no, you're unavailable, and just focus on you. Just focus on you and studying until you get through next week. All right. Well, as always, folks, be kind to yourselves, be kind to each other, take care of yourselves, and if you can, help take care of each other, and we'll see you soon. Cheers.
Thank you.
Take care as well.
Thank you. And I'll get that other document loaded up in the next 10 minutes or so.